He was interested to present one free paper in our Telangana State Conference, and she will present the free paper. Then after, I will announce the judges, sir.
Okay, okay.
Thank you, sir.
Madam Sarita, please present.
Yes, sir. Thank you so much, sir.
Please start.
Good morning, my teachers and my friends. I welcome you all for the virtual case presentation session today. My name is Dr. Sarita. Today I'm going to talk about the clinical study, differential diagnosis, and the management of unilateral sensorineural hearing loss. Let me start by giving you a background information about the unilateral sensorineural hearing loss, which are still in focus. I would like to concentrate on the etiology, the clinical features, investigations for the diagnosis and the treatment. All these things has to be in a detailed clinical characterization of these patients, which will lead us for the further investigations and also the treatment. The aim of my study was to find the different causes for unilateral sensorineural hearing loss in adults. And also its various associated clinical features and varied manifestations. The methods were like 50 patients were studied with the unilateral sensorineural hearing loss. Thorough history taking and also ENT examination was done. All the patients underwent pure-tone audiometry and MRI scan of the brain. And the relevant cases, they underwent appropriate investigations like electron-histogram, ENG, and hematological tests like ESR, blood sugar levels, cholesterol levels, triglyceride levels, and also the TSS levels. The diagnosis was eventually made, and then these patients underwent appropriate surgical or medical management, and also the results were analyzed at the end. The results shown were like unilateral SNHL was present in 15% of the patients, OPD patients who attended during the study period. And out of this, 46% of them had profound SNHL. Usually the 52% of the patients had gradual onset in hearing loss, followed by fluctuating hearing loss and also the sudden sensorineural hearing loss. Then the grading, based on the shape of the pure-tone audiometry, it was like low frequency hearing loss was seen in most of the patients. The comorbid status which was associated with these 50 patients were like most of them were diabetic, more than 50% of them, followed by both diabetes and hypertension, followed by diabetes with the one patient who had diabetes and also the post-renal transplant, followed by the dyslipidemia, epistaxis, fatty liver, GERD, and also hypothyroidism was seen. Based on all the investigations, the diagnosis was made. In my study, it was like most of the patients had Meniere's disease, like 28% of them, followed by metabolic cause for the sensorineural hearing loss, then followed by sudden sensorineural hearing loss. And idiopathic, where the cause was not able to find out, we put into a group like idiopathic sensorineural hearing loss, then followed by right acoustic neuroma, 2 patients had, and also there was one patient who presented with left COF, present Mucosal disease. Based on the diagnosis, the treatment was given like most of the patients required only reassurance probably because of the idiopathic cause of the sudden sensorineural hearing loss, and also the metabolic cause. Then medical management was given in 36% of the patients, followed by surgery in the form of stereostatic radiotherapy and also mastoid exploration. The one patient insisted on hearing aid. Then the medical management was given in the form of intratympanic gentamicin injections, then intratympanic steroid injection, and intratympanic steroid as well as IV pentoxaphylline in patients with sudden sensorineural hearing loss. The 2 patients which presented with acoustic neuroma, they underwent stereotactic radiosurgery. As I said, left mastoid exploration was done for 1 patient. So what is my conclusion with all these studies is, the unilateral SNHL is one of the important clinical presentation to the ENT OPD. And by collecting a detailed history, clinical examination, and most of the etiological factors and also the predisposing factors, we can plan a proper treatment as well as the proper investigations as well as treatment. What I would like to recommend is, like, most of the cases of unilateral SNHL will be unknown. The cause will be unknown, but still the baseline investigations like ESR, TSH, fasting blood sugar, PPBS, and lipid profile has to be done to determine the probable etiology for the cause. And all the 50 patients underwent the MRI scan is must and must because because other ear appears to be normal, so we have to rule out acoustic neuroma and also other cerebellar point and angle tumor. And also I would like to recommend like a symptomatic therapy or a adjusted reassurance for the idiopathic SNHL. Actually, for the sudden SNHL, I consider it as a otological emergency and has to be advised immediate therapy in the form of either oral steroids or intratympanic steroids. And these were the few references which I could share with you. That's also. Thank you, sir. Thank you, one and all.
Okay, Dr. Sarita. Sir, Sudarshan Reddy, sir.
Sudarshan Reddy, sir, you are muted, sir. Unmute and talk.
Now, thank you, Madam Sarita. Now we'll start with the first case report presenter.
Sir, one request, sir. The judges will join by 9, sir. They are requested. Just
9,
wait
huh?
for, yes, sir. They have requested. I am calling. Sir, okay.
So
By 9.
what
By
shall-
9.
What
Meanwhile,
shall we do then?
yes. Ask the presenters to just check the presentation. Just 5 minutes. After 5 minutes, Dr. Sriharsha will read out the CV of the judges.
Okay.
Harsha, are you ready with the CVs?
Yes, sir.
Yes. Okay. Just 5 minutes, sir. They will check
Okay.
them. Yes.
Let them
Thank.
check their
Yeah.
presentations, how to share screen,
Yes, sir. Yes, sir.
and then adjust their audio, video,
Yes, sir.
the slides as well as video should be visible so that the judges will judge how the presenter is presenting. And after the presentation is over, you should come out. Share. You should stop sharing so that the other person will start sharing. And this is only for 5 minutes. So try to finish within 4 minutes, 1 minute for questions. So who will see the time, Ramesh?
Sir, I am saying, sir.
Okay. Manoja?
Yes,
Yeah,
sir.
Dr. Manoj is the coordinator for entire session, sir.
Okay. Then I'll just call each presenter.
He will call, sir. No problem, sir. Just to ask.
Okay,
sir.
okay.
I will take
No.
care, sir.
Okay, okay.
Thank you, sir. Thank you.
Thank you, sir. Dr. Sheikh Shafiun. Dr. Sheikh Shafiun. Share your screen. Yeah, make it full screen. Okay. Okay. No, stop. Unmute yourself. You are not audible. Dr. Shafian, your audio is not audible. Still you are not audible. Check your microphone. Is your microphone working? Check your microphone. Next, Dr. Aarti Singh.
Sir, I'm available, sir.
Yeah,
Just
you are audible and share your screen.
yeah. Full screen. Is this okay, sir?
Yeah, okay. Next, Dr. P. Uday Bhaskar. Dr. P. Uday Bhaskar. Dr. A. Shriya Reddy.
Yes, sir.
Please share your screen. Yeah, make it full screen. Okay. Next, Dr. P. Durga.
Yes, sir. Bike rada. Box bike rada. Sit.
Okay. K. Suman.
Stops.
Okay. Next, B. Bharat Kumar. Okay. Naila Nazneen.
Yes, sir.
Yeah. Next, P. Ravali. P. Ravali. Dr. P. Ravali. Muzaffar Hussain. Dr. Muzaffar Hussain. Mark. Ravali Mark. 10, 11. Shafura Sami. Dr. Shafura Sami.
Yes, sir.
Yeah, you are audible. Share your screen.
Manoj,
Sir.
yeah, please stop that.
Okay, sir. Okay, stop sharing your screens.
Yeah,
Ramesh sir will
yeah,
talk.
yeah. Good morning, all the participants and the judges, respected judges, and the session editor. I warm welcome to Dr. Somu Lakshman sir and Dr. Prakash Reducer. Dr. Sriharsha will read out the CV of Dr. Somu Lakshman sir. Then after Prakash Reducer, please.
Respected judges, fellow colleagues, and delegates, we warm welcome to the day 2 of virtual case presentation series. And today we have around 40 candidates lined up for presenting their case reports. And I would like to warmly welcome Dr. Somu Lakshmanan sir from Chennai. He has completed his MBBS in 1996 and MS ENT in 2000. He has worked in Rajat Muthiah Medical College and also followed by Sri Ramchandra Medical College, Chennai. Right now, he is the head of the department and senior consultant in Sri Ramchandra Medical College, Chennai, which is a multi-specialty tertiary care and teaching hospital. He has 19 years of experience in UG and PG teaching since 2002, and he has taken various responsibilities of training MS, DLO, postgraduate students, undergraduate students, nursing, and speech language pathology students. Sir, a warm welcome you, sir.
Yeah, thank you, man. Thank you.
Next, we would like to invite Professor Prakash Reddy, sir. He has done his MS and diploma DNB ENT with 24 years of experience, and he has worked as a professor in various medical colleges. And he has been an examiner for UG and PG. Presently, he runs his own hospital and has it's called Sri Satya Sai ENT Hospital from Kurnool. He has conducted 27 temporal workshops and live ear surgery workshops so far, and he also has done his fellowship otology from Paris and also in group otology Italy. He has presented many paper presentations in more than 170 conferences and has conducted many panel discussions, delivered guest lectures and orations. He was also invited as a faculty at various conferences and done live surgery workshops. He has a special interest in micro ear surgery and pediatric bronchoscopy. So far, he has won around 18 gold medals, and he also regularly conducts free surgical camps for poor and needy patients once in a year. Sir, warm welcome you, sir.
Yeah, thank you, Sriharsha. And also, I'm inviting
Hello.
Dr. Indra. Hello, sir.
You can hear me, no?
Yeah,
Yes,
yeah,
sir.
you can, sir. You can,
Okay.
sir. Thanks. Welcome, sir. Good morning, sir.
Ramesh,
Yeah, good morning, sir.
there's one doubt.
Sure,
So
sir.
they'll present and will not be asking any questions, no?
If they present within 5 minutes, there is a maximum 5 minute time limit is there, sir. We are
Okay.
requesting them to present for 4 to 4.5 minutes. If they have the time only, you can ask the questions, sir. If the time exceeds, no questions allowed, sir.
Okay, thank you.
Yes, sir. Thank you, sir. I'm welcoming Dr. Indra Madam, from former superintendent of ENT hospital, retired superintendent of ENT hospital, as acts as a chairperson, sir. Yeah, sir, you can go ahead, sir.
Thank you. Now the first, Manoj will call the first presenter.
Yes, sir. I would like to call upon Dr. Sheikh Shafiun. Dr. Sheikh Shafiun. Dr. Sheikh Shafiun, you are still not audible. Please check your mic. I am calling the next candidate, Dr. Aarti Singh.
Sir, I'll share my presentation, sir.
Yeah.
Should I start?
Yes, start your presentation.
Good morning, everyone. I am presenting a case report of the dangerous complication of meningitis due to post-traumatic CSF rhinorrhea, a delayed presentation. A 38-year-old female was brought to the casualty with chief complaints of high-grade fever, severe frontal headache, and one episode of vomiting since one day. On further questioning about the symptoms from the attenders, there was history of left-sided watery nasal discharge since 5 months. It was aggravated on bending forward and could not be sniffed back. Past history, she had a history of RTA with head injury 4 years ago. She is a known case of hypertension since 6 years, not compliant with medication for the last 8 months. No history of epistaxis, nasal obstruction, sneezing, or anosmia. No history of seizures, photophobia, ear discharge. General examination. Patient was conscious but in a confused state. No pallor, icterus, clubbing cyanosis, koilonychia, generalized lymphadenopathy or generalized edema. Vitals. Pulse rate was 102 beats per minute. Temperature was 101 degree Fahrenheit. Central nervous system. No cranial or peripheral nerve palsies. Kernig sign, Brudzinski sign were negative. Babinski reflex was also negative. Local examination, nose and paranasal sinuses. External appearance was normal. There was no sinus tenderness. Anterior endoscopy showed right inferior turbinate hypertrophy. On diagnostic nasal endoscopy, we saw minimal watery discharge arising from the roof of left side of nasal cavity. Rest of head and neck stiffness was present. No visual acuity or fundal changes. No papilledema. No cervical lymph nodal enlargement or cranial nerve palsies. Investigations. Spinal tap by lumbar puncture was sent for CSF analysis showing turbid appearance. Bacterial meningitis was diagnosed and Streptococcus pneumoniae was isolated. Left-sided watery nasal discharge was sent for beta-2 transferrin assay and was positive, hence CSF rhinorrhea was diagnosed. MRI cystoscopy was done. It showed a breach involving the left cribriform plate and minimal fluid signal inferior to it in the left side of the nasal cavity. Differential diagnosis is CSF rhinorrhea, chronic rhinosinusitis, allergic rhinitis, and vasomotor rhinitis. Treatment, meningitis was managed by antibiotic ceftriaxone 1 gram IV BD for 14 days till the symptoms of meningitis subsided. Surgery, endoscopic endonasal approach for CSF leak repair was done after the defect was identified. It was repaired using fat, Surgicel, facial lata harvested from thigh, and fibrin glue patch. Post-operative follow-up after 3 weeks and 2 months showed resolution of complaints and no active nasal discharge. Post-operative DNA showed no CSF leak and surgery was successful. This is fascia lata harvested from the thigh, fat plugged in the defect and Surgicel placed, sinuses opened and the leak identified, and fascia lata placed. A fibrin glue was used to seal the defect. This is the fibrin glue we used. And this is a small video showing how the CSF leak was identified by increasing the intracranial pressure intraoperatively. Then fat plugging was done. Then fibrin glue was placed. And this is the post-operative DNA video. Discussion: cerebrospinal fluid is a physiological fluid protecting the brain and maintaining the intracranial pressure. After severe craniomaxillofacial trauma, the destruction of meningeal structures may lead to CSF leak. Post-traumatic CSF leak are seen in 10 to 30% of all skull-base fractures in adults. The risk of meningitis from traumatic CSF leak can present with high morbidity and even mortality. In this case, there was a delayed presentation of post-traumatic CSF leak, which was ignored by the patient and led to meningitis, which could be avoided. Treatment involves intravenous antibiotics as well as primary surgical repair of dural defect. Conclusion: blunt injury of anterior cranial fossa is very common during head injury. Fractures are most common cause of CSF rhinorrhea. The bony defect, size, degree of dural disruption, arachnoid tearing, and intracranial pressure influence the development of CSF rhinorrhea. The timing of CSF leak is important because it will affect the long-term prognosis of patient and complications such as meningitis. Early detection of CSF leak and early surgical intervention is important as it determines the outcome of the patient. These are my references. Thank you.
Hello?
Yes, sir.
Yeah, your third participant, no, Arati Singh.
Yes, sir.
Yes, sir.
What about the first?
Sir, first participant mic is not working. And the second
right.
participant is not there, sir. He is not presenting.
Okay, right. Okay, Uday Bhaskar next.
Next candidate, Dr. P. Uday Bhaskar.
Timing, somebody has to check, Ramesh.
I'm checking, sir.
Because how they exceeding the time, we are not.
No, sir. I'm checking, sir.
No, at the end of presentation, you tell they are on time.
Okay, sir. Okay, sir.
Yeah.
Good morning, everyone.
Dr. P. Uday Bhaskar.
Good morning, everyone.
Start your presentation.
Sir, am I audible? Sir?
Talk loudly.
Yeah, you are audible.
Yes. Good morning. Good morning. Good morning, everyone. My case report is a case of unresolving distressing recurrent laryngeal papillomatus. Introduction. Recurrent laryngeal papillomatus is the second most common cause of hoarseness in the children after vocal nodules. It is a wart-like irregular or ectopic lesion of airway. Recurrent laryngeal papillomatus is characterized by the recurrent proliferation of the papilloma anywhere from the nasal vestibule to the terminal bronchi. Here we may present unresolved distressing recurrent laryngeal papillomatus in a 50 years old patient. Here we like to present a case of a case of 50-year-old female patient resident of Karimnagar who is a BD worker by profession, came with a complaint of voice change since 5 years, which is who is a BD worker by profession, came with a complaint of voice change in 5 years, which is incidence in onset, gradual and progressive, hoarseness in character, persistent, no aggravating and relieving factors, no issue related to the complaint. Patient is known case of hypertension in 5 years. History of similar complaint in the past is 20 years, for which he underwent a microangial surgery 20 years ago and 10 years ago. Internal examination. Patient is conscious, coherent, and oriented to time and place. Patient is well built, well nourished, no pallor, rectus, rubbing, lymphadenopathy, cyanosis. Vitals are normal. Systemic examination is normal. Local examination, reddish, multiple grape-like warty lesions arising from the anterior 1/3 of the left vocal part, covering the anterior portion of the rima glottidis, which moves with inspiration and expiration, and posterior 2/3 of 2/3.
Hello.
Hello, I think Uday's voice is not coming, sir.
I'm going to ask them to increase the voice in the computer because his voice is very feeble.
Hello.
Uday?
Yeah,
Hello?
go ahead.
Yeah.
Steps of the surgery. Initially,
Uday, you are not audible. Dr. Uday?
This is an image showing a green-like water lesion using a Skinner blade. This lesion is debrided and removed. This image shows skimmer life and the lesion, which is debriding and removed. This image shows after the lesion is removed, gauze soaked in adrenaline is placed and the bleeding is controlled. This image shows the whole lesion is debrided and removed, and there is no mucosal injury. A few bits of lesion is sent for biopsy. Restricted lesion debrided and removed in total. Post-op patient is followed for up to 2 months. Video endoscopy is done on the first week and repeated every 2 weeks. At the end of the patient again developed a single irregular mass lesion on the left vocal cord, just behind the previous surgical site. Patient is advanced for the
1 minute left.
Injection of the bevacizumab. Discussion: recurrent laryngeal papillomatis is also called as recurrent respiratory papillomatis. It is a benign lesion, most etiology, HPV 6 and 11 and most common types, and voice abuse. Recurrent laryngeal papillomatis classified into juvenile onset recurrent laryngeal papillomatis and adult onset recurrent laryngeal papillomatis. Patient presented with history of the hoarseness of voice, stridor, respiratory distress, chronic cough, failure to drill, recurrent pneumonia. There is a chances of malignant transformation into squamous cell carcinoma up to 2.5%. Diagnosis by the flexible rigid laryngoscope reveals multiple grape-like water lesions in the larynx. Histologically, it presents as finger-like projections of a non-keratinized satisfied squamous epithelium. This is confirmed by the microlaryngoscopy.
Dr. Uday, your time is up.
Treatment by the cold state excision, microdebrider with skin alive, or on laser ablation. Conclusion: treatment is difficult to treat because of its tendency to recur and spread toward the digestive tract. Aim of the treatment is to improve airway and voice while decreasing the spread, preserving the normal structures. These are the differences. Thank you.
Next presenter, Dr. A. Sriharsha Reddy. Start your presentation.
Good morning, judges, seniors, and my dear colleagues. This is Dr. Shreya. I am going to present a rare case of glomangiopericytoma in the nasal cavity. Glomangiopericytoma is a rare sinonasal tumor which is emerging from the Zimmerman's pericytes. It accounts for less than 0.5% of the all sinonasal neoplasms seen in 6 to 7 decades of life with female predominance. GPC was previously reported as hemangiopericytoma and was initially described in 1942 by Stott and Murray as a soft tissue tumor with distinctive vascular proliferation, including branching vessels and small vessel perivascular hyalinization. In 2005, WHO has recognized GPC as a borderline low malignant potential soft tissue tumor of nose and paranasal sinuses with excellent survival rate. Coming to the etiology, it remains unknown due to high vascularization, hypertension, trauma, pregnancy, and long-term use of corticosteroids are considered the possible causes. Presenting a case of a 60-year-old male patient with left-sided nasal obstruction and 2 episodes of epistaxis since 1 month. No history of trauma, pain, nasal discharge, orbital complications noted. He is a known hypertensive case on regular medication. General examination is normal. Coming to the local examination, on local examination, mass is seen medial to the middle turbinate. Reddish mass is seen medial to the middle turbinate in the left nostril. Left deviated nasal septum noted. Posterior rhinoscopy appears normal. On endoscopic examination, smooth reddish mass arising medial to the middle turbinate, which is soft in consistency and mobile in the left nostril noted. Probe cannot be passed medially and it is bleeding on touch. Coming to the differential diagnosis, angiofibroma, vascular leiomyoma, lobular capillary hemangioma, and solitary fibrous tumor. Coming to the CT scan, here we can see the well-defined soft tissue density lesion noted in the left nasal cavity. In contrast, we can see the heterogeneous enhancement. Biopsy was taken and sent for histopathological examination, which revealed glomangiopericytoma. Histopathological examination reveals spindle-shaped cells with ovoid nucleus and eosinophils. Varied size of blood vessels with branching are noted like stag house appearance. This is a small video. This is the septum. Here we can see the middle turbinate. The growth is excised. After excision of the growth, the base is cauterized with the help of a corblator to secure the hemostasis. After corbulation, we are going to place Abgel. These are the surgical steps. Excision of the growth is done, base is cauterized, and Abgel is placed. Patient missed follow-up. He presented with Sinus after 3 weeks, which were relieved with the help of laser. Coming to the discussion, glomangiopericytoma is a rare tumor in the nasal cavity. It accounts less than 0.5% of the nasal tumors. It is seen in 6 to 7 decades of life with female predominance. The chief complaints are epistaxis and nasal obstruction. Histopathology always remains the definitive diagnosis. It is an indolent tumor with overall excellent survival rate. When complete excision is achieved, complete surgical excision is a standard treatment for glomangiopericytoma. Radiotherapy is reserved only for the cases that are inoperable or metastatic. Coming to the conclusion, glomangiopericytoma is a rare indolent neoplasm of the sinonasal region. Reporting of this case will help in increasing knowledge, aid in establishing of the diagnosis, and creating definitive guidelines for the treatment of glomangiopericytoma. These are the references, sir. Thank you.
Any questions, sir?
What are the differential diagnoses you would like to think for this case?
Angiofibroma, vascular leiomyoma, lobular capillary hemangioma, solitary nodules.
Okay.
Was it involving sphenoid?
No, sir, it was not involving sphenoid side. It was present on the posterior part of the septum in between the middle turbinate.
Okay.
And the next candidate, Dr. P. Durga.
Yes, sir.
Yes, sir.
Trying with this laptop. But इधर डिस्कनेक्ट किया है यार.
अच्छा अदा కాదు కదా ఇది కదా.
Good morning, sir. An unusual presentation of capillary hemangioma. Coming to introduction, hemangioma is a tumor which is characterized by the proliferation of blood vessels resembling the normal vessels, but the proliferation is unclear whether they represent the vessel malformations or true neoplasm or hemangiomatous overgrowth. Hemangioma localized in craniofacial area accounts for 60%, but the oral involvement is rare. Hemangiomas may appear as a pale macule with thread-like telangiectasia may be noted on the skin. Large lesions are usually disfiguring and can be associated with high morbidity if located near vital structures. A 40-year-old female presented to our department with the swelling over the inner aspect of the lower lip, inner aspect of the upper lip since 1 year, and the swelling was initially peanut sized and which was gradually progressive, extending into the anterior aspect of the left nasal cavity. It is not associated with any pain, discharge, and bleeding. No history of difficulty in opening mouth, nasal obstruction, and dental infection, and no history of trauma. On detailed dental, medical, and family history, no are non-contributory to the condition. On intraoral examination, which revealed a reddish pink solitary well-defined non-ulcerated growth over the upper mucogingival junction. From mucogingival junction involving the maxillary labial frenulum along the alveolar mucosa and through the superior labial soft tissue extending into the anterior aspect of the left nasal cavity as an ovoid mass involving the floor and the vestibule. The lesion was approximately 3.8 into 2 centimeters covering the 3/4 of the crown involving the maxillary central incisors and the canine. On palpation, the inspectory findings are confirmed and the lesion was firm in consistency, non-fluctuant, non-tender, and no local rise of temperature and non-transilluminating with restricted mobility. The differential diagnosis include angiosarcoma, nodular Kaposi sarcoma, verrucous hemangioma, and tufted angioma. On CT, paranasal sinuses revealed a well-defined hypodense lesion involving the superior labial tissue extending intranasally, which is of size 4 into 2.6 centimeters, crossing the midline. As the lesion was well localized, surgical excision was considered as a treatment of choice. Gingival cervicular incision was given along the periosteal margins and the flap was raised laterally from the premolar area of both the sides, and the flaps was raised in a trapezoid fashion and the soft tissue dissection was done. Not much bleeding was noticed during the surgery and excision was done in toto with well-defined margins and interdental matter suturing was done. Hemostasis was secured and the patient was discharged after 2 days. On 7th post-operative day, the wound remained healthy. Coming to histopathological examination, the lesion was lined by the keratinous stratified squamous epithelium with focal ulceration and the underlying lesion comprising of variable sized capillaries which are separated by the endothelial cells and intervening stroma, and there is no any evidence of atypia. Coming to the discussion, capillary hemangioma is caused by the proliferation of the large endothelial cells and anastomosic blood-filled channels. The exact nature of these vascular tumors is not known, which may arise secondary to some event in utero. That is, the placental cells such as trophoblasts may be the cells of origin for hemangiomas. Capillary hemangiomas are the most common benign tumors in infancy. Coming to pathophysiology, when there is the arrest in the development of the mesenchyma as the differentiation progresses, the primitive vessels penetrate deeper into the subcutaneous layer, muscle and bone, and resulting in the capillary hemangioma. Coming to the conclusion, capillary hemangioma constitutes for about 60% of the craniofacial involvement, with the oral and mucosal involvement is rare. Capillary hemangiomas are infrequently seen on the mucogingival junction and may be easily confused with the different lesions, particularly with the angiosarcoma.
Early detection and excision biopsy are necessary to determine the clinical behavior and should take necessary precautions to handle the bleeding. These are my references. Thank you.
Any questions, sir?
What is the unusual presentation of this?
Sir, from the mucogingival junction, it is extending into the nasal cavity through supralabial tissue, sir.
Why was not a biopsy planned for this patient?
Sir, because it's a highly vascular area, so we thought that excision in toto will be the good option.
Yeah. So what are the precautions you have taken, because you said it's a highly vascular tumor?
Sir, we have making a blood reserve, sir, because it's a highly vascular area. There are the chances of bleeding.
Okay. Thank you.
Yes, sir. Thank you, sir.
And the next presenter, K. Suman.
Good morning, sir.
Start.
Good morning, sir. Retention cyst, deep lobe of parotid gland, a rare case report. Introduction: cystic lesions within the parotid gland are uncommon, and clinically they are frequently misdiagnosed as tumors. The incidence of benign cystic lesion of parotid gland is relatively low, comprising approximately 5% of all parotid tumors. They usually present with equal distribution between the males and females as unilateral tendon swelling in the area of parotid gland without fixation.
Please click slideshow.
Sorry. Case history: a 35-year-old male patient presented to our operation department complaining of swelling over the right side of the face, in front and below the right ear since 6 months. The swelling was insidious onset, gradually progressive, and attained the present size. It is not associated with pain and discharge. There was no history of difficulty in swallowing and facial weakness, and there was no history of trauma and previous surgeries in facial region. Local examination: on inspection, a single swelling of size about 3 into 4 centimeter, oval-shaped swelling in right preauricular and infra-auricular region extending around 2 centimeters below the lobule of right ear with lifting of the earlobe. On palpation, inspectory findings were confirmed by palpation. Swelling was soft in consistency, mobile, non-tender, no recurrence of temperature. Skin over the swelling was pinchable and non-pulsatile. Intraorally, there was no swelling present, no regional lymphadenopathy. Coming to ear and nose oral cavity examination were found to be normal. Differential diagnosis: preauricular lymphadenitis, pleomorphic adenoma, bronchial cleft cyst, epidermoid cyst, benign lymphoepithelial cyst, Warthin's tumor, mucoepidermoid tumor with cystic degeneration and retention cyst. Coming to investigations: routine blood investigation were done and found to be normal. On ultrasonography, suggestive of chronic parotid simple cyst, and FNAC suggestive of cystic lesion of the salivary glands. Coming to CT scan, a well-defined 30 into 32 into 42 mm encapsulator heterogeneous hyperdense collection noted in deep lobe of a parotid, that is on right side, a likely right intraparotid abscess. Management: preauricular cervical flap was raised and the cyst capsule was easily separated from overlying skin. Cyst mass was reduced with aspiration of fluid. All the branches of facial nerve were exposed. The base of the lesion was attached to the parotid gland by a stalk of fibrous tissue. The mass was finally dissected free from the parotid gland by excision of the stalk, along with the small amount of the glandular tissue. Post-operatively, patient develops right-sided lower motor type of facial palsy. Grossly, the specimen measures 4 into 3 centimeters. Right-sided, that is from the parotid. Microscopically, histopathological examination revealed parotid structure with a cyst with a thick capsule comprised of fibrocartilaginous tissue, lymphoid cells, plenty of thickened vascular spaces, and congested capillaries. Cyst is lined by the flattened cells, pigment-laden macrophages, no lymphoid follicle, suggestive of retention cyst of parotid. This is the 1 week post-op period where the patient develops the right lower median palsy and right facial palsy. After a course of 4 months of steroid therapy, patient become normal. Coming to discussion, retention cyst most commonly involves
1 minute left.
minor salivary glands, and they rarely involves the major salivary gland. However, when they occur in major salivary glands, parietal gland is affected more frequently by cyst and congenital lesions than any other major salivary glands. Other condition which non-parenchymal tissue origin can result in cyst-like lesions in parietal area. They are tuberculous non-specific abscess and parasitic cyst. The pseudocertified columnar to cuboid epithelium, presence of dilated excretory ducts and lack of aggregate of lymphatic follicles clearly distinguish the parietal retention cyst from the Wharton tumor, epidermoid cyst, and lymphoepithelial cyst. Mechanical trauma, laceration, chronic obstruction due to stricture, and presence of cellulitis and chronic cellulitis can account for formation of certain proportion of parietal retention cyst. It also been postulated that some of these cysts are developmental or congenital origin. In a series by Peters and Seymour AE 183 surgical parietal gland specimen, 16 parietal cysts were, out of which 7 were true parietal. Of the 7 true cysts, only 1 was the retention cyst and the rest were the epidermoid and lymphoepithelial cyst. In another series by Richardson, 23 reported cases, 5 cysts were retention cyst. Apart from these 2 reports, there are only sporadic cases of parietal retention cyst. Coming to conclusion, retention cyst of parietal gland origin is extremely rare and diagnostic challenges, but still retention cyst should be considered as a differential diagnosis in case of painless parietal swellings which are soft and consistent. These are my references.
Next candidate, Dr. B. Bharat Kumar. Start your presentation.
Morning, judges. The case report of nasal and cutaneous rhinoscleroma. Introduction. Rhinoscleroma or respiratory scleroma, a progressive granulomatous condition affecting the upper airways. The infection occurs due to gram-negative organisms like Klebsiella rhinoscleromatis. The infection tends to occur predominantly among the rural population where socio-economic conditions are backward. Causes include overcrowding, poor hygiene, poor nutrition, etc., which facilitate the spread of rhinoscleroma. Case history. 32-year-old male residing in a rural area working as a laborer came with the chief complaints of occasional nasal bleed from right nostril and bilateral nasal obstruction since 6 months. Patient was apparently asymptomatic 6 months back. Then he developed bleeding through right nostril, which was insidious in onset, associated with bilateral nasal obstruction, which was predominantly on right side. Other associated symptoms include crusting in the right nostril. There was no history of foul-smelling nasal discharge, anosmia, nasal deformity, dysphonia, no history of ear and throat complaints, no significant medical illness or surgeries or chronic medication intake in the past, and no significant family history. General examination, which patient is conscious, coherent, cooperative, moderately built and nourished. There is no pallor, icterus, clubbing, cyanosis, lymphadenopathy and pedal edema. Vitals are stable. Blood pressure is 120/80. Pulse rate is 80 beats per minute. Temperature is febrile. Respiratory rate is 16 cycles per minute. Local examination. External nose and framework appears to be normal. On anterior rhinoscopy, single reddish fleshy mass with granular surface seen at anterior end of the inferior terminate, which was extending up into the right nasal cavity with attachments on both septum as well as the floor of the nasal cavity. It is not mobile, insensitive to touch, firm in consistency and bleeds on touch. Probe cannot pass medially and inferiorly. Posterior rhinoscopy, cone clear. Investigations. Routine blood investigations were done and were normal. Diagnostic endoscopy shows reddish fleshy mass in the right nostril, which was extending into the floor and nasal cavity. Nasal swab sent for culture and sensitivity showed presence of gram-negative organism. CT-PNS revealed multiple hypodents, non-enhancing soft tissues, polypoidal lesions of various size in right nasal cavity arising from the nasal septum and floor of the nose. There was no evidence of intra-lesional calcification or bony destruction of the surrounding area. This was the CT-PNS, and this is the hypodens lesions. And these on histopathological examination, we can see Mucosal cells, which are round oval vacuolated macrophages in which Klebsiella rhinoscleromatis resides, and these are Russell bodies. Russell bodies are the eosinophilic spherical granules, and the other cutaneous manifestations which include lesions over the left forearm and left shoulder. Management. The patient was planned for surgical excision of the mass, and after pre-operative evaluation and anesthetic checkup, he
1 minute left.
Surgery with right nasal mass excision under endoscopic guidance with cauterization of the base of the removed lesions. The sample was sent for histopathological examination, which revealed the hyperplastic mucosa with pseudoepitheliomatous squamous hyperplasia, granulomatous inflammation, foamy macrophages containing the bacteria, and the plasma cells with Russell bodies suggest to the diagnosis of rhinosclerosis. The patient has significant relief of symptoms following the surgery, and he was discharged post-operatively, stating oral antibiotic tetracycline 500 mg twice daily for 14 days. Patient was followed for 3 months with good clinical outcome and no evidence of any recurrence of symptoms. Diagnosis is cutaneous rhinoscleroma. Discussion. Rhinoscleroma is specific granulomatous infection that affects the nose and nasopharynx and less frequently other structures of the respiratory tract. They are progressive in 3 stages: cathedral stage, hypertrophic stage, and sclerotic stage. Our patient presented with disease in this hypertrophic stage of rhinoscleroma, which was managed combined approach of surgical removal of mass along with follow-up and antibiotic therapy with tetracycline. Conclusion. In conclusion, patient present with hypertrophic or granulomatous stage of rhinoscleroma without any deformity underwent necessary investigations and managed promptly with surgical intervention and oral antibiotic therapy, provided good outcome and management. Hence, early intervention with adequate follow-up, patients will definitely add an asset for our career. These are my references. Thank you, sir.
And the next candidate, Dr. Naila Nazneen.
Yes, all the best. Good morning, everyone. I'm here to present a rare case of pyogenic granuloma in a 12-year male child, which is a rare case and unusual to see at a vestibule area. Since 1 month. The patient was apparently asymptomatic 1 month back. Then he developed bleeding from the left nasal cavity, which was insidious in onset, moderate for a few minutes, and which was subsided spontaneously. There were 3 such episodes in a month with no aggravating factors. There was no history of trauma to the nose, no history of nose picking habit, and no history from the bleeding from the other sides. There was no history of complaints like nasal obstruction, nasal discharge, nasal pain, nasal crusting, or disturbances in smell, or no history of foul smelling. There was no history of change in speech or facial pain or facial heaviness or nasal discharge. There was no history of snoring and mouth breathing, and no history of ear complaints and throat complaints. Past history, there was no history of hypertension, diabetes, and any thyroid abnormalities. Drug history, there was no history of intake of drugs like antiplatelet drugs. Personal history is normal. The appetite was normal, and bowel bladder movements are normal, and no allergies and addictions were seen. On journal examination, patient was moderately built and moderately nourished, and the vitals were stable. Systemic examination, respiratory system, cardiovascular system, and per abdomen was normal. No abnormalities were seen. On ENT examination, on examination of nose and PNS, external framework was normal. On tip rising test, vestibule area, there was a pinkish mass seen arising from the vestibule was seen. Columella was normal, and caudal end of septum was normal. On anterior rhinoscopy, there was a 0.5 into 0.5 centimeters pinkish fleshy mass was present in the left nasal cavity at the vestibule at the junction of medial and lateral walls, and the swelling was insensitive and did not bleed on touch, and it is soft in consistency. And on probing, and probe could be passed all around except superiorly. This is the image showing the anterior rhinoscopy where the fleshy pinkish mass can be seen. posterior rhinoscopy was normal, and functional tests of nose, cotton wool test, and bilateral equal movements were seen, and cold spatula test, bilateral equal mist formation was seen. Examination of oral cavity, oropharynx, and was normal, and indirect laryngoscopy, examination of neck, and examination of ear was normal. Tuning fork tests were with a normal range. Investigations to be planned was contrast enhanced CTs of nose and paranasal sinuses. So my provisional diagnosis of my case is bleeding polyp of the left nasal cavity. The differential diagnosis of my case can be a capillary hemangioma, secondary the hemangiopericytoma, and the other can be a cavernous hemangioma or a malignant melanoma or a squamous cell carcinoma. Investigations which were done for my patient was diagnostic nasal endoscopy. The diagnostic nasal endoscopy was performed with a 0-degree endoscope, and a pinkish fleshy mass was revealed, which was present at the left vestibule area. This is the CECT report showing the mass in the left vestibule area of the patient. And this is the report of the following CECT. The surgical profile was done, and everything was in normal limits. Excision of bleeding polyp under general anesthesia, as the patient is a 12-year-old male child, as he was uncooperative, so we had taken him under general anesthesia. These are the images following the post-op excision. Post-operatively, the patient was managed of all of this. The patient was nil by mouth and given all this treatment. This is the histopathological image showing the capillary lobular in the lobular pattern and the infiltrates. This is the histopathological report, which suggests of pyogenic granuloma. So my final diagnosis of my case is pyogenic granuloma of the nose. Discussion. It is also known as a capillary lobular hemangioma. It is a benign vascular lesion that affects the skin.
1 minute left.
Mucous membranes affecting the nose. It generally presents as a painless pink or red solitary papule. It's most commonly associated with hormonal changes, mostly as in pregnancy and oral contraceptives, and secondary to trauma. The diagnosis is usually clinical when the patient presents with the lesions. And the most common treatment is common surgical techniques are surgical excision and the primary closure. Conclusion, our case is being presented as it is unusual to see this condition in males, that too without any prior history of trauma, and it is concluded that pyogenic granuloma can occur in males and other sites of nose like vestibule, though rare in incidence. Thank you.
Any questions, sir?
Hello?
Hello, sir.
Yeah, why did you mention tuning fork test in this case?
It is a part of ENT examinations.
Has it got any relevance actually?
No, sir. If there is the tumor present in the posterior nasal cavity, sir, extending to the nasopharynx, then it can block a eustachian tube. Then we can have a decreased hearing, sir.
Okay, right.
I would like to call upon Dr. P. Ravali.
Thank you.
Dr. P. Ravali. Dr. Muzaffir Hussain. Dr. Shafura Sami.
Yes, sir. A very good morning to all. Today, I would like to present a case of bilateral elongated styloid process, a case report on Eagle syndrome.
Increase your volume.
Okay, sir.
Yeah.
In 1937, an otolaryngologist named Eagle described the elongation of the styloid process or calcification of the stylohyoid ligament as Eagle syndrome. An incidence of 4% of the general population has been given. It is generally asymptomatic or occurs with vague symptoms. It is more common in adults of age ranging from 30 to 50 years and more commonly seen in females. The elongation of the styloid process can be bilateral or unilateral. The average length of the styloid process is 20 to 30 millimeters in adults. Now, today I'm going to present the case of a 41-year-old male patient that presented to the OPD with complaints of bilateral orofacial pain, left side more than the right, since 6 months. The pain was spontaneous in origin, dull to moderate in intensity, and intermittent in nature. Pain was needle-like piercing type of pain over the preauricular, post-auricular area, and it radiated to the temporal as well as the ipsilateral lateral side of the neck. The pain aggravated by movements such as looking up and turning the face side to side, and also during yawning. He also gave a history of difficulty in swallowing since 2 months, which was associated with spurts of pain that was radiating to both the ears. The patient had tried several analgesics and NSAIDs over a period of time. However, the symptoms were not relieved. He also had symptoms of reflux and halitosis. There was no history of any swelling and no history of any association with fever. The past history showed no relevant medical history and no history of any trauma or any surgeries in the past. Personal history: he has been experiencing disturbed sleep due to aggravated pain. There was no relevant family history. On examination of the ear, the pinna and the external auditory canal were normal. The tympanic membrane was intact. Examination of the nose showed no abnormality. Extraoral examination: the face was symmetrical. There was no palpable mass or tenderness in the involved region. There was no tenderness elicited in the muscles of mastication during palpation. Bilateral temporomandibular joints showed normal movements and no tenderness. Neck examination was also normal. No lymph nodes were palpable. Intraoral examination: the lips, tongue, buccal mucosa, teeth all appeared to be normal. There was a grade 2 tonsillar hypertrophy in this patient and without any congestion. Now, on a bimanual examination using gloved fingers, the patient actually experienced extreme tenderness, and also a hard bony mass was felt in both the tonsillar fossas. A provisional diagnosis of elongated styloid process was made. For investigations, an orthopantogram followed by a cone beam computed tomography of the left and the right styloid process was advised. The orthopantogram showed an abnormally elongated styloid process measuring 36 millimeters on the right side and 37 millimeters on the left side, whereas the CBCT showed 35.8 on the right and 41.4 on the left. This here is the OPG showing 36 on the right and 37 millimeters on the left side. This is the coronal and axial view of the CBCT, where it shows 35.8 on the right side and 41.4 on the left side. Lower down is the sagittal view for the left styloid process. Here we're having the right styloid process sagittal view, as well as the reconstructive images, which are highly useful for knowing the adjacent anatomical structures as well as the angulation of the styloid process. Treatment: as the patient had already been subjected to analgesics, NSAIDs, and diazepam earlier but failed to show any response, surgical treatment was advised. Transoral tonsillostyloidectomy under general anesthesia was given. Now, under general anesthesia, an endoscope was used in this, and we actually, following tonsillectomy, the tonsillar bed was palpated. The tip of the styloid process was identified. Using a ring curette, it was stripped from tip to the base, and a kerosene sponge was used to nibble off the exposed styloid process. The tonsillar bed was sutured with absorbable sutures. Post-operative analgesics and antibiotics were used. Post-op event showed an uneventful recovery and no complications. This is the tonsillar fossa, and these are the excised elongated styloid processes. Discussion: the syndrome is symptomatic. So in this syndrome, there's symptomatic elongation of the styloid process or the calcification of the stylohyoid ligament. Average length is 2.5 to 3. Eagle actually gave trauma, chronic irritation, and surgeries like tonsillectomy to be one of the cause, which will actually compress the vessels and nerves surrounding the styloid process. It may also
Your
be
time is up. Next presenter, Dr. V. Vaishali. Dr. V. Vaishali.
Yes, ma'am, I'm here, ma'am. Am I audible, ma'am?
Yes, yes.
I'm not able to share my file. Is my screen visible, ma'am?
No, your screen is not visible.
Just a second, I'm sorry. Ma'am, now?
Yes.
Good morning, everyone. My name is Dr. V. Vaishali. Today, we'll be seeing a case report on tuberculous mastoiditis. Extrapulmonary TB manifesting as tubercular otitis media is a rare atypical presentation, which accounts for only about 0.05 to 0.9% of all the CSOM cases. TB mainly affects the middle ear through three routes: the eustachian tube, bloodborne dissemination, or direct implantation through the EAC, and tympanic membrane perforation. We'll be discussing a case history of a 35-year-old female who presented to the ENT OPD with chief complaints of impaired hearing in the left ear since 3 months, swelling behind the left ear since 10 days, and left ear pain and discharge since 10 days. She was apparently asymptomatic before 3 months, and then she developed complaints of impaired hearing in the left ear, which was insidious, progressive, and non-fluctuant. She had a history of swelling behind the left ear since 10 days, which was initially small in size and gradually increased to attain the present size. She had left ear pain since 10 days, which was acute, persistent, and a throbbing type of pain, which was not relieved by medication. There was a history of left ear discharge since 10 days, which was insidious, continuous, mucopurulent in consistency, not bloodstained nor foul smelling. And there was also a history of ringing sensation. There was no history of ear bleed, giddiness, or itching sensation in the ears, and there were no signs of intracranial complications or no history of any constitutional symptoms. She had no known comorbidities, no history of trauma, and no history of contact with any TB case. Her past, present, and family history were nil significant. Her general examination and systemic examination were normal. On ENT examination, her right ear was completely normal with an intact tympanic membrane. In the left ear, an oval swelling of size 2 into 2 centimeter was seen in the post-auricular area, a little above the mastoid region, and the skin over the swelling appeared to be normal with no discharging sinuses or scars. On palpation, it was tender. There was no local rise of temperature. It was mobile, firm in consistency, and the skin over the swelling was pinchable. The EAC showed congestion. The mucosa appeared to be edematous. A pinkish mass seemed to be arising from the posterior wall of the EAC, completely occluding it, sensitive to touch, and didn't bleed on touch. There was mucoid discharge over the pinkish mass. The tympanic membrane could not be visualized. Mastoid tenderness was present. Tuning fork tests, the Rennie's test showed positive in all the 3 frequencies in the right ear, whereas in the left ear it was negative in 256 and 512 and positive in 1024 Hertz. Weber's was lateralized to left. Absolute bone conduction test was same as the examiner on both the ears. Bilateral facial nerve function was intact. Nose examination, oral cavity and oropharynx and neck examination were normal. Basic investigations were done. All of them were found to be normal, with ESR elevated at 50 mm at 1 hour and 70 mm at 2 hours. Specific investigations, Manto was done and it was found to be positive with a 22 mm induration. Sputum for AFB and CBNAT were negative. On pure tone audiometry, she showed a 42 decibel moderate mixed hearing loss in the left ear, and pus from the post-auricular abscess was sent for CBNAT, which was also negative for Mycobacterium tuberculosis. HRCT temporal bones were done, and it showed a soft tissue density in the left hypo, meso, and epitympanum with an erosion of the mastoid bone, tegment tympani, and sputum. All these findings suggestive of an otomastoiditis or a cholesteatoma. Examination under microscope revealed a pale granulation tissue which arose from the posterior wall of the EAC, completely obscuring the tympanic membrane. She was taken up for mastoid exploration under general anesthesia. Intraoperatively, the mastoid cortex was completely filled with granulation tissue, which was sent for histopathological examination and CBNAT. On HPE, she had all the features which were suggestive of a chronic caseating granulomatous inflammation, and the CBNAT of the tissue was positive for Mycobacterium tuberculosis. Management, pulmonologist's opinion was taken, and they had advised to start first-line anti-tubercular therapy with a combination of isoniazid, rifampicin, pyrazinamide, and ethambutol under the DOTS regimen. After 3 months of ATT, the patient was followed up, and she had symptomatically improved. Discussion. Tuberculosis has been a global health concern for long, and in developing countries like India, it is a major
Last
cause of
1 minute.
mortality and morbidity. The classical features of TB otitis media is a painless, odorless otorrhea with multiple perforations of the tympanic membrane and granulation tissue, the most common mode of infection being spread from the lungs. Anti-tubercular therapy can be started on a clinical or histopathological basis. I'd like to conclude this by saying that primary TB mastoiditis without pulmonary involvement in an immunocompetent individual is a rare clinical entity. Therefore, early diagnosis and early institution of treatment is mandated to prevent complications such as facial paralysis, hearing impairment, and intracranial spread of infection. ATT remains the mainstay of treatment. These are my references. Thank you.
Any questions, sir?
Hello, sir. Good
Yeah,
morning,
why
sir.
did you mention that in extra-arterial canal mucosa appears edematous? Because from where there is no mucosa in extra-arterial canal. Why did you mention that? Go back to your slides later and check, not now. You mentioned that mucosa appears edematous.
Okay, sir.
Is it wrong or right?
It is wrong, sir. Sorry, sir.
Now, next question to you.
Yes.
Suppose if you just remove that polypoid tissue in the extra-arterial canal and send it for histopathology,
yes, sir.
It would have been enough, or surgery would have been the mainstay of treatment in this patient?
Sir, biopsy would have been enough, sir, but actually it appeared pulsatile on diagnostic nasal endoscopy, sir. So we had a doubt if it could be vascular also. So we didn't want to take the risk, and hence she was taken up for exploration, sir.
Okay, right.
Next, Dr. MD Shafiuddin. Dr. MD Mohammad Shafiuddin.
Hello, am I audible?
Yes, yes.
Okay.
Share the full screen.
Yes. Hello. Good morning, judges and my seniors. I'm Dr. Shoaib, presenting a case report on functional parathyroid carcinoma in adolescents.
Yeah, this
Introduction.
is number 14, no?
Number 14, sir.
Yeah, what happened to this 12 and 13?
So 12 and 13 have completed, sir. Dr. Vaishali and Dr. Shafura Sami.
10 and 11 are not come.
Yes, sir. 10 and 11 are not online, sir.
Sir, you can put as absent, sir. No problem.
Ma'am, I'm there.
No? Just a minute,
I'm
just
there,
interrupt you.
Dr.
No. Now, just now presented is the Ravali, no? Just
No,
now
sir.
presented
Dr.
Vaishali.
Mohammad Shafiuddin.
No, Vaishali, no?
Yes, sir. Vaishali. Dr. Vaishali.
Ma'am, number 10 is here. My mic is
11,
not working.
11?
Sir, 10 and 11 mics are not working, sir. They
Now
just
it's
now
working,
came to
ma'am.
online, sir.
Yes, ma'am.
Not
No,
that
but
they
just,
have...
no, just a minute. There's a lot of confusion. Now, see, 12 is not presented, no?
Yes, sir. No, sir. 12 has completed the presentation, sir.
10 and 11 are not presented, sir. It is number 9, and after that 12.
Please mention, see now, 10 and 11 are not presented.
Yes, sir. Yes,
No,
sir.
sir.
10 and
They have
11
not presented, sir.
I'm here, sir, but I can present next.
Yeah, see, this is the thing. When they are not presenting, please tell us, no? There's
Okay,
some
sir.
confusion here.
Okay,
right.
sir.
Now, just to recall, who is not there, you just tell us, no?
Okay, sir. Sir, number
not
one, Dr. Sheikh Shafiun has not presented, sir, till now.
Okay,
The mic is not working, sir. Number 10, Dr. P. Ravali has not presented, sir. Her mic is not working, sir.
Number 2?
Number
Number 2 is
11.
also not presented. Number 2 is also not presented.
Okay, number 10 is not presented. Next?
Number 11, sir.
Okay. Okay, right, okay.
No, number 14. Number 14, sir.
Yeah, okay, right.
Number 14.
Go ahead. Go ahead.
Start your presentation.
Good morning, judges and my senior faculty. I'm Dr. Shoaib, presenting a case report on functional parathyroid carcinoma in adolescents. Introduction. The primary hyperparathyroidism is a very rare condition in pediatric population with an estimated incidence of 2 to 5 cases per 1 lakh of population. Parathyroid carcinoma per se is a very rare, extremely rare endocrine malignancy, which is seen in 3 to 5 cases per 10 million of population. In pediatric population younger than 16 years, only 13 cases have been reported. Today, one case came 12-year-old female, which she was presented with neck swelling since 2 years, difficulty in swallowing since 3 weeks. On history of present illness, swelling was over left lower neck since 2 years. Incidence since onset, gradually progressive, increasing, associated with pain and nausea, no aggravating or relieving factors. There was a difficulty in swallowing for 3 weeks for solids. Incidence since onset, non-progressive, no aggravating or relieving factors. It was not associated with vomitings. There was no history of fever, vomitings, or trauma or hoarseness of voice. There was no history of, in past history, there was no history of TB or diabetes or asthma. There was no history of any chronic medication use or any surgeries. Family history was not significant. Personal history, she was having decreased appetite. Menstrual history was regular. On general examination, patient was thin built and well nourished. On general examination, patient was conscious, coherent, vitals were stable, no pallor, icterus, clubbing or chylomicria or lymphadenopathy. On local examination, an elliptical swelling in left side of the neck measuring about 5 into 3 centimeters, located just 3 centimeters above manubrium sterni, which was moving with deglutition, not moving with the protrusion of tongue. Skin over the swelling was normal, and swelling is firm in consistency, non-tender, non-fluctuating, non-pulsatile. There was no local rise of and it was non-transluminant. Oral cavity, throat examination, nose examination, bilateral ears examination, all normal. On neck examination, there was no lymphadenopathy. Cranial nerves were normal. We advise ultrasound of neck, which showed the well-defined hypoacute lesion of 5 into 3 centimeters with focal areas of internal vascularity and small punctate echogenic foci, which suggested lower neck lesion with possibilities of exophytic solitary thyroid nodule or parathyroid adenoma. Then further we evaluated with FNAC, fine needle aspiration, which showed Bethesda 5 classification, which was suspicious for malignancy. Then we advised the computed tomography of neck with IV contrast, which showed the 11 into 5 into 2 centimeters smooth marginated lobulated hypodense hyperenhancing nodule, which was arising from left lobe of thyroid, demonstrated curvilinear intercalcification and non-enhancing hypodense areas with the retrosternal extension and mass effects, which was likely large solitary thyroid nodule, medullary thyroid carcinoma or parathyroid adenoma. On serology, apart from all routine investigations, her serum calcium was elevated. It was 12.66 milligrams per deciliter. Her intact parathyroid hormone was grossly elevated with 106 picogram per milliliter. Her thyroid profile was normal. Her serum calcitonin was normal. The patient underwent left hemithyroidectomy under general anesthesia. These are the intra-op images and specimen. Post-op, the patient on day 7, her serum calcium came back to normal, that is 9 milligrams per deciliter, and her post-op intact parathyroid hormone came back as normal. Immediate post-op, we were anticipating severe hypocalcemia, and she showed the signs of hypocalcemia. We managed through titrated dose of calcium gluconate. HP showed the parathyroid carcinoma with thymic remnant. These are the HP images. We went for IHC, which showed GATA3 and PCK positive. GATA3 is specific for parathyroid carcinoma. The diagnosis of carcinoma is histologically made with chief cells in solid sheets, proliferated blood vessels, tumor shows capsular or vascular invasion. IHC for GATA3 confirms the diagnosis. Discussion. Parathyroid carcinoma is very common in, it is common in 4th and 5th decade of life with a slight male predominance. Management is en-bloc resection, which offers the better survival rates. AJCC TNM classification, for my case, it was T3 N0M0. There are only 8% of chances of local recurrence and overall survival rate of 89%. Parathyroid carcinomas are usually radiotherapy resistant. So surgical resection offers best survival outcomes, which is superior to radiation. Parathyroid carcinoma is rare entity and its incidence is very extremely rare. Thank you, sir. These are my references.
Your time is up.
Thank you.
Just a minute, Shreya. Sir, respected judges and the chairperson, with your permission, small announcement, sir. Sorry for interruption. Shreya, where is Manoj?
Sir, I am here, sir.
Yeah,
Sir, is there, sir?
please call upon whoever are left over, please.
Sir.
The remaining members, just number wise, you call upon them. If they are present, just present, finish up them. Okay, don't go in a hurry. Okay.
Okay.
Just inform clearly serial number, name of the candidate, and call upon.
Yeah,
and
there is
inform.
lot of confusion because see, somebody is coming, somebody is presenting. See, whoever is absent, you please tell them, because if they are online, okay. By any technical fault, if they are unable to present, you can allow them. But if they are not there, come at the last minute, it's no.
Okay, sir.
Yeah. Now, who is not presented? 1 and 2 not presented, no?
Yes, sir. One is not presented, sir. 2 is it is not in the list, sir. It is actually.
No, foreign body in the trachea.
Yes, sir. That is actually poster, sir.
Okay, there. Okay, right. Okay, 1 and 2 cancelled, no?
1 is present, sir, but her mic is not working, sir.
Yeah,
So
call
she
her.
did not present.
Okay, now 10 and 11 not presented, no?
No, sir.
Yeah, okay, you can give them chance if they are.
Okay, sir. Sir, shall I call number 1, sir? Dr. Sheikh Shafium?
No problem.
Okay, sir. Dr. Sheikh Shafium?
Number 2, you can put absent, sir.
Yes, sir.
They have given, but they don't want to present now.
Dr. Sheikh
Hello?
Shafium?
Hello, ma'am. Am I audible now, ma'am?
Yes, you are audible. Share your screen.
Increase your volume.
Yes, sir, I need some time to present, sir. Actually, there's a lot of confusion.
Okay, you can present in the end, last presenter.
And next
Okay,
10
sir.
and 11.
I will present at the end, sir.
Okay.
Okay,
10 and
okay,
11.
sir. Thank you, sir. Thank
Sir,
you so
shall
much.
I call number 10, sir?
Okay, no problem.
Okay.
But
Doctor,
I also feel that anybody who is not presented or not ready, let them present at the end. Let
Okay,
they are
sir.
ready, only present now.
Yeah.
Sir, shall I call number 10, sir?
Yeah, probably 10 we can finish off. And
Yes,
after
sir.
that, if there's a delay, let them finish. We'll give a time. Let them try to do at the end.
Dr. 10, Dr. P. Ravali.
Who is this Muzaffir?
Sir, I'm Dr. Huda.
That is number 11, sir. Number 11.
Okay, go ahead. 11, go
Am I
ahead.
audible, sir?
Yes, yes.
Yeah.
Okay, sir. Thank you.
Start your presentation.
Esteemed members of the faculty, seniors, and my peers, a very good morning to one and all. I'm Dr. Huda Muzaffar Hussain, and I'd like to share a case report of a 23-year-old male patient who presented to us with a bony facial swelling. He is a 23-year-old male, welder by occupation, presented with a swelling over the left cheek, which led to obvious facial asymmetry, which bothered him a lot. On further questioning, we came to know that the swelling was present since 1.5 years. It was gradual in onset, progressive, and more so in the past 3 months. It was associated with foul-smelling discharge from the left nasal cavity, associated with burning sensation and nausea as well. He gave occasional history of passage of crust from the left nasal cavity. Sir, am I audible and visible?
Video is not visible.
Okay.
Your presentation is not seen.
Your presentation is not visible.
Okay, ma'am, I'm again putting it up. Am I visible now?
Yes.
Thank you.
Share it full screen. Okay.
So there is occasional passage of black colored crust from the left nasal cavity. There is no associated complaints of nasal block, paresthesia over the cheek, bleeding from the nose, loss of smell, headache, ocular symptoms, fever, or change in skin color. The patient gives us history of trauma to the left central incisor, followed by dental crown placement 1 year before the development of this swelling. He is addicted to tobacco chewing since 10 years. There are no associated comorbidities like diabetes mellitus, hypertension, TB, epilepsy, etc. There is no history of usage of long-term medications like steroids. The general examination and the systemic examination of the patient appear to be normal. On examination of the nose via anterior rhinoscopy, there is right deviated nasal septum and left inferior turbinate hypertrophy. On examining the swelling, we found that it was the left anterior cheek swelling of 5 into 5 centimeters, oval in shape, smooth surface, no redness or sinuses present over the skin. It was hard to palpate, non-tender and immobile, while the examination of the neck showed that there was left submandibular lymphadenopathy present. So until now, we had that this could be a malignant-like presentation. So we put up a few differential diagnoses in front of us. The most common one being the first sinusitis, the next carcinoma of the maxilla, few others like fibrous dysplasia of the maxilla and ameloblastoma. To guide us further, we did a CT scan of the paranasal sinuses, which showed us soft tissue density in the bilateral maxillary and ethmoid sinuses. The left maxillary sinus showed erosion of the walls, predominantly the anterior wall, with extrasinus extension into the soft tissue, into the subcutaneous planes of the premaxillary region. The routine blood investigations came out to be normal. The diagnostic nasal endoscopy showed that there was left high DNS, right anterior DNS, and pinkish polypoidal mass was present at the left middle meatus, which bled on touch. So, to arrive on a confirmatory diagnosis, we performed the biopsy and we came to know that it was a case of chronic invasive granulomatous fungal sinusitis, which was consistent with aspergillosis. As the specimen showed extensive fibrosis, multinucleate giant cells, and the Grocott-Smithamin silver stain showed fungal profile with acute angle branching confirming to Aspergillus species. Angioinvasion was present as well. HRCT of the chest appeared to be normal. So we planned for the treatment, which included surgical plus medical management. The surgical management was done under general anesthesia, which included left inferior turbinectomy, plus left anterior plus medial maxillectomy, plus left orbital floor rim was removed, and right maxilla was cleared of the fungal debris via a Cadwell Luck approach. The medical management included tablet itraconazole 200 milligram twice daily for 1 year. Follow-up of the patient was lost due to unknown reasons. Coming to the discussion. Fungal sinusitis was initially considered to be a rare disorder, but currently the cases are on a rise. Clinically, it is divided into acute and chronic, acute being less than 12 weeks and chronic being more than 12 weeks. Based on histopathological evidence of fungal invasion of the underlying tissues, it is divided into non-invasive and invasive varieties. The invasive varieties include acute fulminant, chronic invasive fungal sinusitis, and chronic granulomatous invasive fungal sinusitis, which is our case. In most of the invasive fungal sinusitis cases, the patient is immunosuppressed due to one or the other reason. But chronic granulomatous invasive fungal rhinosinusitis is one case where immunocompetent hosts are usually involved. The key points include that these cases are seen in immunocompetent hosts. Aspergillus flavus is the most exclusive pathogen. This is seen predominantly in India, Pakistan, Sudan because the tropical climate provides good atmosphere for fungal infection growth.
You can move on to next.
Conclusion is that there is increased demand which requires better understanding. Thank you, one and all.
Hello?
So
Hello?
next.
No, I just want to ask her one question. Why did you why did you people choose that external approach to manage this? It can be managed with endoscopically, no?
Sir, it showed erosion of all the walls of the most of the anterior wall, and orbital floor of the orbit was also involved. So we approached via raising the cheek flap.
Do you think that
better exposure?
It can be done with endoscope still?
Endoscopically, based on the extent seen on the CT scan, it can be done on endoscopically as well, sir, but we thought the fungal debris could be cleared off nicely and maxillectomy could be performed via an open approach.
Okay.
Thank you, sir. Thank you, sir.
So shall I call the next presenter, sir?
To the next one.
So the next presenter, Dr. CH Madhumita. So number 15, Dr. CH Madhumita.
Hello, ma'am. Ma'am,
What happened to this
I have a technical issue, ma'am. Can I present the next in the next series, ma'am, please? Just after our presentation, because I have a technical issue. My laptop is just hung. So can I come after one presentation?
No
So
problem.
Dr. C.H. Madhumita is having network issues.
We'll
Sir.
go to the next one. We'll go to the next one.
Okay, sir.
Thank you, sir.
Dr. Kiran S. Raghav.
What happened to 10, number 10?
So she's not. Dr. P. Ravali.
Ma'am, Ravali ma'am is not presenting, ma'am.
She's not presenting.
Yes, yes.
Let's go to the next one. Who is ready?
So Dr. 10 P. Ravali is not presenting, sir.
Then okay, no problem. 15,
15 having network issues, sir. She will present later.
16. Right, okay, right, 16.
16, Dr. Kiran S. Raghav. Dr. Kiran S. Raghav. Dr. Kiran S. Raghav, are you there?
If not, move to the next one.
Dr. K. Monica Reddy.
Yes, ma'am, I'm there. I'll share my presentation.
Please increase your volume and share your screen.
Is my screen visible, ma'am?
No, not yet.
Yeah, yes.
Can I start, ma'am?
Yeah, you can.
Good morning, everyone. Today I'm going to present a case report on a rare case of Syringocystidenoma papilliferum.
Make your screen full. Dr. Monica Reddy.
Yes, ma'am. Yes. My aim is to present a rare case of Syringocystidenoma papilliferum in posterior auricular region. Syringocystidenoma papilliferum is a rare benign adnexal tumor of the apocrine or the ecrine type with characteristic histological findings. 50% of the cases are reportedly present at birth, while 15 to 30% are present during puberty. This tumor commonly occurs in the head and neck region, most commonly seen in scalp region. I'm going to present a 19-year-old female patient presented to our OPD with complaints of swelling in right posterior auricular region. Since
Dr.
1
Monica, your screen is not visible.
One second. Ma'am, now?
No, your screen is visible. Start the presentation. Yes.
19-year-old female patient presented to our OPD with complaints of swelling in right posterior auricular region since 1 year. No history of pain over swelling, gradually increasing in size, no history of ear discharge, or no history of any constitutional symptoms. On clinical examination, a single 2 by 1 centimeter well-circumscribed nodular swelling noted over right posterior auricular region. Swelling was firm in consistency, mobile, and non-tender. Skin over the swelling was normal. Routine blood investigations were normal. Fine needle aspiration cytology smears were highly cellular and cells had moderate amounts of cytoplasm with eccentric round nuclei, and picture was suggestive of benign adnexal tumor. Excision biopsy was done under local anesthesia and tissue was sent for histopathological examination. Histopathological examination showed multiple cysts lined by 2 layers of cells, outer cuboidal and inner columnar, and cysts showed papillary invaginations, which is suggestive of benign adnexal tumor, Syringocystidenoma papilliferum. Histopathological examination showed papillary invaginations surrounded by cystic areas and tubular glands. Discussion: Syringocystidenoma papilliferum is a benign adnexal tumor of the apocrine or ecrine type. Clinically, most of the cases are seen at birth and during puberty. There are 3 clinical types: plaque type, linear type, and solitary nodular type. Plaque type is more common in scalp region and associated with nevus sebaceous. Nodular type lesions has predilection for trunk, but in our case, it was present in posterior auricular region. Characteristic histological findings include enlarged cystic cavity with papillary structures,
and syringocystadenocarcinoma papilliferum, and few cases of varicose and ductal carcinomas are reported to arise from syringocystadenoma papilliferum. Rapid enlargement and ulceration of the lesion is indicative of malignant transformation. As there is risk of malignant transformation, surgical excision with detailed histopathological examination is the mainstay of treatment. In this patient, the lesion was excised under local anesthesia and she recovered well with no recurrence after 6 months of follow-up. Conclusion is syringocystadenoma papilliferum is a rare benign tumor. Though it usually appears at birth, it can be present in adults too. Though nodular variety has predilection for the trunk, here it is presented in posterior auricular region. As there is potential of malignant transformation, it should undergo complete surgical excision and histopathological examination. These are my references. Thank you, sir.
Sir, any questions?
What was your differential diagnosis when you thought before planning for surgery?
Diagnosis was keratoacanthoma and dermoid cyst lipoma.
How do you say it's a lipoma and a dermoid cyst as a differential diagnosis?
It was
What made you to think it's a dermoid cyst?
posterior.
It's okay, we'll go for the next presentation.
Dr. G. Purushottam Reddy.
I think Dr. Madhumita wants to present.
Yes, sir.
Yes, sir. Yes, sir.
Yeah. Please announce your serial number and inform us.
Sir, Dr. Madhumita, serial number 15, sir.
15, sir. Yes, sir. Yes. Sir, can you see my screen, sir?
No.
Okay. Just a minute, sir. I'm sorry for the lag. I'm really sorry. Yeah.
Yes. Make it full screen.
Just a minute. Just a minute. Can you see it,
No problem. You go ahead.
ma'am? Yes,
Okay,
sir.
sir.
Make it full screen and go ahead.
Yes, sir. Good morning, sir. This is Dr. Madhumita. I would like to present a case of iatrogenic facial palsy, which presented to our OPD and how we managed it. Yeah, this is a 50-year-old female who presented to her OPD with symptoms of giddiness and unilateral facial nerve palsy on the left. There was lower motor neuron type of palsy. After she was operated somewhere else on post-op day 13. There was asymmetry on rest and incomplete closure of eye and inability to move.
Your first slide only is seen. Second
Your
slide.
slide is not moving, man. Your slide is
Go
not
to the next
moving.
slide. Come down. Use the down arrow. Don't worry.
Madhumita,
Now, sir?
I'll guide you. Wait. Exit your screen share.
Yes, sir.
Stop
Yes,
your
I
screen
did.
share.
Yes, sir.
Now okay.
No, sir. I'll guide her now, sir. It will be a mistake again. Just to stop your screen share.
Okay, sir. Just a minute, sir. Rachita, can you help me? Yes, sir.
Now you start your screen share and select screen. Okay, when you click share, select screen.
Select screen.
Okay, when you click share, you'll
Yes,
find an
sir.
option called screen. Okay, do
Yes,
that and you
yes,
start your presentation again.
Yes, I selected it, sir.
Go full screen slideshow.
Now, sir. Now, can you see, sir? I'm changing it, sir.
No. Okay. Just go ahead like this.
Can you see the slide, sir?
can
Or
see the
shall
second
I
slide.
go without a full screen, sir? Yes, sir. Yes, sir. Can I go without a full screen,
No
sir,
problem.
if
You
it is
can
possible?
continue.
Yes, sir. Yes, sir. Thank you, sir. I'll come again, sir.
Yeah.
This is a case of 50-year-old female who presented to the OPD with the symptoms of giddiness and unilateral facial nerve palsy, left-sided, lower motor neuron type. After being operated elsewhere, on the post-op day 13, she presented to our OPD. At presentation, it was of house Bregman grade 5. And we did a CT scan, which showed soft tissue density in the left mastoid, erosion of the left semicircular canal, and dehiscence of fallopian canal, sir. In this section, we can see an intact mastoid segment on the right, whereas on the left, it was not clearly seen. Because the patient also had a grade 5 palsy, we suspected a complete nerve transection and went about with it with the plan of canal wall down mastoidectomy with facial nerve decompression with or without cable nerve grafting. Incision was given on the previous scar, the post-oral William Wild incision, and surface markings for the greater auricular nerve were made, and it was extended into the neck, sir. And the dissection was done. The greater auricular nerve was identified just beneath the platysma on the sternocleidomastoid muscle and was harvested. This is a image intraoperatively as soon as we exposed the cortex. There was drilled out mastoid. It was not properly saucerized. We proceeded with a canal wall down mastoidectomy in order to identify the landmarks and also to expose the facial nerve in its complete extensor. The findings were transection of facial nerve, 5 mm proximal to stylomastoid foramen, 3 mm defect with granulations at the cut ends, and a drilled out lateral semicircular canal exposing the membranous labyrinth. So we proceeded with facial nerve decompression, 1 centimeter proximal and distal to the injury, freshened the margins, and cut a 45 degrees fresh cut. Then we went on with the cable nerve grafting using the greater auricular nerve that was harvested in a laziest manner with a tripod suturing. We used a 6O proline, sir, but ideally we should use a 8O to 10O monofilament, nylon or polypropylene. The patient was managed post-operatively with intravenous antibiotics, steroids, facial exercises, and physiotherapy. Patient was followed up 3 monthly over the 6-month period. The facial palsy improved to House Bregman grade 3 and repaid facial nerve recovery score C. And now the patient is still on follow-up, sir. Discussion: percentage of iatrogenic facial palsies falls between 0.6 to 3.6%, 0.8 being according to Royal College of Surgeons. Most common area of injury is distal tympanic segment, second genu more than mastoid segment. Management of iatrogenic facial palsy includes facial nerve decompression, nerve grafting, end-to-end anastomosis, facial reanimation procedures. Cable grafting was chosen in this case to obtain a tension-free anastomosis, and greater auricular nerve was chosen because it approximates the size of facial nerve. It was present in the field of surgery, and it provides a graft of up to 12 centimeters long. Other techniques of facial reanimation were considered if there was no improvement post-op. Why this case? Because mastoidectomy is one of the most commonly performed surgeries. Understanding anatomy of facial nerve in tympanomastoid ear surgery is a mandate for every surgeon. We would like to give an insight with this case that how to manage an iatrogenic facial palsy with a loss of nerve tissue, where end-to-end approximation with tension-free is not possible. However, other facial reanimation procedures do have their role. These are my references, sir. Thank you. I invite for any questions, sir.
Sir, any questions, sir?
Yeah, number one, you said
Yes,
that there is a fistula of the lateral canal.
Yes, sir.
And you said you have drilled out the labyrinth.
It was pre-operatively drilled out, sir.
Number one,
yes,
why
yes, sir.
if there is a fistula, you have to repair it. Why did you further drill? Number one, and you have not mentioned any repair of the lateral canal.
Yes, sir. We did, sir. We did, sir. There was erosion of the bony labyrinth, and membranous labyrinth was intact, sir. So we repaired it with a temporalis fascia graft, sir.
Bony labyrinth, no. When there is a fistula, there will be a fistula. That's all. There will not be any intact membranous labyrinth. Actually, once you open, it is open. That's all. You can see the intent, and there is no video also, and the picture is not clear here. You cannot identify. And so, okay, then how did you repair that?
So we put actually intraoperatively membranous labyrinth was intact, sir. Only the bony labyrinth was eroded. So we put a temporalis fascia graft, sir.
Then why did you mention that lateral canal is drilled out? Why did you drill out? Why did you drill out?
We did not drill out, sir. It was pre-operatively. This is a post-op case, sir. It was operated elsewhere. The patient presented on day 13 of post-op, sir.
You have not done anything.
No, sir. No, sir.
Is there a better way to repair the lateral canal fistula?
Bone wax can be kept, sir. Bone wax or plugging with muscle graft or fat can be used.
Okay, right.
Yes, sir.
Thank you. Sir, shall I call the next presenter, sir?
Yeah.
Sir, number 18, Dr. G. Purushottam Reddy. Dr. G. Purushottam Reddy.
Good morning. Good morning, sir.
Okay.
Share your full screen.
I'm Dr. G. Purushottam Reddy. I'm presenting a case report of carcinoma of posterior pharyngeal wall. Introduction: the posterior pharyngeal carcinoma are rare. The mean age at presentation is 60 years. It demonstrates male dominance. It has significant association with alcohol and smoking acting synergistically. Predominantly, these are all squamous cell carcinomas. Presentation: a 49-year-old female patient came to ENT OPD with chief complaint of foreign body sensation in throat since 9 months, difficulty in swallowing since 6 months. It was slowly progressive, continuous, more to solids than liquids. History of change in voice present since 3 months. History of tobacco sniffing since 10 years present. History of significant weight loss present with loss of appetite. General examination: patient is conscious, core and cooperative, thin belt, blood pressure is 130/70, right arm, supine position. The pulse rate is 82 beats per minute, regular rhythm, normal volume, respirator 16 per minute, saturation is 98% with room air. Temperature is febrile. Local examination and oropharynx: ulcer of proliferative growth present over posterior pharyngeal wall extending to left vocal cord is fixed in video laryngoscopic examination, which indicates involvement of larynx is present, and laryngeal crepitus is also absent. It indicates involvement of post-cricoid region also. And on neck examination, single palpable jugulodigastric node, hard in consistency, measuring about 2 centimeters is present. This is preoperative VLA showing the growth present posterior pharyngeal wall, extending posteriorly, inferiorly. Investigations of flexible fiber optic endoscopy, tumor of hypopharynx, extension and movement of vocal fold can be assessed with this investigation. Contrast studies with barium swallow. By using this modified Valsalva Tony B maneuver, it is possible to distend hypopharynx and allow the barium to coat the mucosa. CT scan used to evaluate the extent of the hypopharyngeal cancers. It can identify the tumor itself, surrounding structures, larynx and thyroid. Assessment of the likely involvement of the cervical node. MRI is superior to CT scan, demonstrating soft tissue abnormalities such as prevestibular fascia invasion. PET used with the contrast 18 fluorine 18 fluorodeoxy glucose has high sensitivity, but it can detect the occult residual and recurrent tumors, but has low specificity. The combination of PET and CT increases the specificity. Provisional diagnosis: the malignancy of posterior pharyngeal wall with secondaries in neck. This is treated with the posterior pharyngeal wall malignancy is managed with the external beam radiotherapy with doses of 66 grays, 33 fractions, 2 grays per fraction to head and neck region for a period of 6 weeks. This is post radiotherapy VLS showing the tumor is regressed. Discussion: the posterior pharyngeal wall malignancy is a part of hypopharyngeal malignancy along with other sites of hypopharynx, of piriform sinus and postcricoid area. The carcinoma of posterior pharyngeal wall is rare among these three. It comprising 7% of all hypopharyngeal cancers. These are reported to be silent in early stages. Around 60% of patients present with stage 3 or 4 disease. Further, around half of patients are reported to have poor performance status at presentation. The cancer of posterior pharyngeal wall usually presents as an ulcer that infiltrates the whole of the posterior wall, both superficially and deeply, and may involve from nasopharynx down to the upper esophagus. Tumors may spread to involve prevertebral muscles. retropharyngeal space and may spread laterally to involve both pyriform sinuses. The lymphatic spread mainly to level 2, 3, 4 and retropharyngeal nodes.
Last 1 minute.
In apopharyngeal cancer, because of its advanced presentation and involvement of extension to cross midline and risk of contralateral metastasis is high, specific attention needed for other lymph nodes like parapharyngeal, paratracheal, and mediastinal lymph nodes also. The distant metastasis is reported up to 3% cases. Mostly sites involve lungs, liver, bones, and brain. Treatment. The early apopharyngeal carcinoma is treated with like surgical excision with or without neck dissection, either it is endoscopic or open. The conservative surgery with or without bilateral selective neck dissection with or without post-op radiotherapy or chemotherapy. Concurrent chemoradiotherapy to primary site both necks. Neck radiotherapy alone, where significant comorbidity prevents the above options. The locally advanced hypopharyngeal carcinoma was treated with concurrent chemo with or without bioradiotherapy to primary and neck. Radical surgery, pharyngolaryngectomy with or without reconstruction, with or without
Your time is up.
selective modified neck dissection with post-operative chemoradiotherapy. Thank you.
So shall I call the next presenter, sir?
Yeah, I think the previous one, just one small information that you said there's ulcerative growth in the posterior phalangeal. You didn't mention or describe anything about the mass or lesion. And just to highlight about your presentation, I think we can go for the next one.
Yes. So shall I call number 19, Dr. B. Sandeep?
Okay.
Dr. B. Sandeep.
Not ready?
Not present.
We'll go to the next
Shall
one.
I go to the number 20, Dr. J. Harshavardhan?
Good morning, sir.
Yeah, good morning.
Screen.
Dr. Harshavardhan?
Yes, ma'am. 1 minute, ma'am. Good morning, sir. I'm presenting a case report on a Kimura disease affecting the post-auricular region. And a 30 years old male patient came to our OPD with complaints of swelling behind the left ear since 4 years. History of present illness. The patient was apparently normal 4 years back. Then he observed a swelling behind the left ear, which is insidious in onset, gradually progressive, associated with itching sensation over it, and no history of pain, no history of fever, no history of ear discharge, and no history of hearing impairment. Past history, not in one case of hypertension, diabetes mellitus, bronchial asthma, tuberculosis, coronary artery disease, cerebrovascular disease, no history of previous medical and surgical history. Family history, not significant. General examination, no pallor, no icterus, no cyanosis, no clubbing, no generalized lymphadenopathy. And local examination, and the ear, left ear, pinna, normal, preauricular, normal, post-auricular region. On inspection, we can find a 6 into 8 centimeter single ovoid swelling on left post-auricular region. Surface is smooth, skin is tense, no scars, surrounding area, no pigmentation, edema, no visible pulsation. On palpation, inspectory findings are confirmed. No localizer temperature, non-tender, firm in consistency, non-compressible, non-pulsatile, skin non-pinchable, lesion is not freely mobile. On external artery canal normal, tympanimemoral normal and intact, tragal sign absent, mastoid tenderness absent, right side of the ear is normal, nose anti-rhinoscopy normal, posterior rhinoscopy normal, oral cavity normal, oropharynx normal, neck trachea in central position, laryngeal cryptus present, no stridor, carotid pulsations are palpable, and systemic examination, CVS S1 S2 present, no murmur, respiratory system, bilateral air entry present, no additional sounds per abdomen, and which is soft central nervous system, no focal neurological deficit. And the overall clinical presentation was suggestive of a benign subcutaneous lesion or left post-auricular region. A differential diagnosis could be a lipoma, fibroma, dermoid cyst, epidermoid cyst, lymphadenopathy. And the blood investigation showed slightly raised eosinophils and raised serum total IgE levels. Radiological investigation showed USG, no evidence of fluid CT, no involvement of underlying structures or bone. Audiological investigations are normal. Fine needles aspiration cytology showed scattered lymphoid cells, predominantly small mature lymphocytes in some hemorrhagic background, suggestive of reactive lymphadenitis. A course of broad spectrum antibiotics was prescribed for 7 days, but the lesion did not subside, so we proceeded for excisional biopsy under general anesthesia. Histopathology showed stratified squamous epithelium with underlying large areas of fibrocartilaginous connective tissue, showing numerous collections of mature lymphocytes forming lymphoid follicles. Lymphoid cells are mixed with numerous eosinophils forming focal collections. There is a mild capillary proliferation seen. These lymphoid follicles are seen invading the subcutaneous tissue. Lymphoid follicles showing innumerable eosinophils with deposits of eosinophilic proteinaceous material. We can see post-op care and management of wound essence, POD7 and POD10, POD14 and POD18, POD20. We followed up to 1 year and there is no recurrence has been seen. Discussion: Kimura is a rare disease described as a eosinophilic hyperplastic lymphogranuloma. It is endemic to Asia, more common in males than females. Kimura disease is a benign chronic inflammatory disorder with unknown etiology. It almost exclusively involves a head and neck region, such as the post-auricular, parotid, lymph nodes, and subcutaneous tissue. It's a immune-mediated hypersensitivity, which is hypereosinophilia and elevated serum Ig levels are features. Kimura disease has been confused with angiolymphoid hyperplasia with eosinophilia, can be distinguished by having a more fibrous component. Diagnosis of Kimura disease is always a clinical dilemma with no specific diagnostic guidelines. The histological picture with the formation of lymphoid follicles and the intense aggregates of eosinophils with sometimes form microabscess, vascular proliferation and fibrosis is highly suggestive of Kimura disease. Treatment alternative for Kimura disease consists of surgical resection, cytotoxic and radiation therapy, as well as regional or systemic therapy. Treatment with intralesional corticosteroid or triamcinolone acetate has been reported to have a good outcome. Relapses are common, but recurrence rate is as high as 40%. Overall outcome is good as there is no association with malignancy. Conclusion: even though rare, Kimura disease should be considered in the differential diagnosis of recurrent head and neck subcutaneous mass.
Last 1 minute.
FNAC is a supportive tool, but histopathology is indispensable for diagnosis. The aim of management primarily is preserving function and cosmetics of the tissues affected, although prognosis can be good and a complete cure is sometimes unattainable. Thank you, ma'am.
Any questions, sir?
So why was the ultrasound done for this patient in the post-oral region?
Done, sir. There is no fluid collection, but not there, sir. Report.
Yeah, right. But why did you do an ultrasound for that? No, I saw that because one of the investigations put this ultrasound.
Sir.
Why did you go ahead and do an ultrasound for this?
Ultrasound was done, sir. No evidence of.
Right. Thank you, man.
Oh, thank you, sir.
So shall I call the next presenter, sir?
No, I just want to ask him.
Sir.
Your plan for a surgery, but surgery intra-op swelling you are not shown. How big was the swelling? When you remove the swelling,
sir,
there is no video or photograph of the intra-op one.
Yes, sir.
Yeah, that is number one.
Yes, sir.
And you said you planned for a surgery, but surgery is that is done or not, you have never mentioned. Directly you went to the histopathological examination. You please correct that. Okay.
Yes, sir. Thank you, sir. Thank you, sir.
Yeah. Okay.
Thank you, sir.
Shall I call the next presenter, sir?
Next.
Number 21, Dr. B. Deepika.
Yes, ma'am.
Please increase your volume.
Good morning, all.
Take your presentation.
Yes, ma'am. Am I audible, ma'am?
Yes, yes.
Is my presentation is visible, ma'am?
Yes, Deepika, it is visible.
Okay. Good morning, all. Myself, Dr. Deepika. I'm presenting a case of oral plasmacytosis, which is a rare case. Coming to introduction, plasmacytosis is a chronic multifocal idiopathic non-neoplastic plasma cell disorder of the mucous membrane of upper aerodigestive tract like oral cavity, nasal cavity, nasopharynx, larynx, oropharynx, and esophagus. Not more than 50 cases were reported in the literature. The clinical appearances of oral plasmacytosis are varied, but typically it presents as a erythematous oral mucosa with cobblestone, nodular, papillomatous, granular, or velvety surface changes. Coming to case report, a 34-year-old male patient named Rajesh presented to outpatient department of ENT with complaints of swelling over inner surface of the upper jaw since 2 months. Swelling was gradually increasing in size, associated with pain which is localized to the swelling, continuous and dull, aggravated during mastication, associated with bleeding during mastication, and he had no history of swallowing difficulty, nasal obstruction, and bleeding from nasal cavity, and he had no history of decreased appetite and weight loss. Coming to past history, there is no significant past medical and surgical history, and he had no history of tobacco addiction and smoking. On examination, patient is conscious, coherent, and with no signs of pallor, icterus, cyanosis, lymphadenopathy, and edema. He is febrile with pulse rate of 78 beats per minute, and blood pressure is 110 by 80 millimeters of mercury, and respiratory rate is 16 cycles per minute. On intraoral examination, a 3 into 2 centimeter sized irregular erythematous growth noted over inner surface of the upper jaw, extending from hard palate to maxillary vestibule. Tongue, buccal mucosa, uvula, soft palate, anterior and posterior pillars, and posterior pharyngeal wall are normal. On palpation, lesion is soft in consistency, nodular, tender, and profusely bleeding on probe test. We conducted investigations like complete blood picture, liver function test, and renal function test, which are normal. And on the axial section of computed tomography scan revealed a hypodense lesion in left anterior maxillary region, indicating unilateral osteolytic destruction of the labial cortical plate, extending from midline to canine region. And we conducted an excisional biopsy under local anesthesia, and we sent sample for histopathological examination, which showed diffuse dense infiltrate of mature plasma cells, and acute inflammation is noted, and there is no evidence of granuloma. As histopathology revealed plasma cell disorder, we conducted special investigations like serum electrophoresis, urine test for benzone proteins, and immunohistochemistry. Serum electrophoresis revealed an increase in alpha, beta, and gamma globulins, that is polygammopathy, which excludes which excludes malignant conditions like multiple myeloma and plasma cell leukemia, in which there will be monoclonal gammopathy. And serum electrophoresis, there is no discrete M protein band is noted, which excludes malignant conditions. Urine test for benzone proteins was negative. This excludes multiple myeloma. On immunohistochemistry, it revealed kappa and lambda stains and showed positive plasma cells. With clinical history, investigations, and histopathology and serum electrophoresis, it revealed a non-malignant inflammatory or reactive growth, most likely oral plasmacytosis. So after excisional biopsy, patient was treated with oral and topical steroids. Oral prednisolone was given 60 mg TID for 2 months, and betamethasone topical application was given. Then oral steroids were tapered over a period of 1 month with regular monitoring of long-term steroid therapy. Coming to discussion, plasmacytosis is more common in males than in females, with a mean age group of 56 years. And this literature suggests that various allergens may cause plasmacytosis, but there is no evidence. But no evidence could be found. Several treatment approaches can be used, like systemic steroid therapy, cryotherapy, radiotherapy, carbon dioxide laser excision. Coming to conclusion, clinical and histopathological features of plasmacytosis resemble many common benign and neoplastic conditions of the oral cavity. The exact etiology of plasmacytosis is not known, but it may be due to hypersensitivity reaction to unknown environmental antigens. Hence, it is a diagnosis of exclusion requiring multidisciplinary evaluation, long-term follow-up, and new treatment strategies are therefore required. These are my references. Thank you.
Any questions, sir?
Yeah, no questions. Yeah, hello, Ramesh.
Sir.
Ramesh?
Sir, hello, sir.
I think we have completed our job.
Sir, for 2 more candidates are there, sir. After that.
No. First, see, you said 20 people, no? No, this is the 21st candidate.
No, sir. In between, we have missed some candidates, sir. That's why I'm requesting you.
They are there? In between people?
Yeah. After that, also, in the serial number 22 and 23 will present, sir, now. Afterwards, we will see, sir.
No, you have other set of people, no?
No, not that. Not the other set. Simple case report up to 40 members are reports only, sir. Just I'm asking to 20 people, sir. Total 20 candidates, sir. So remaining, I will
Ramesh,
Next over Monica.
hello.
Sir, shall we proceed, sir?
No, you want us to be again there for another some time? No?
Two candidates, sir.
Yeah, we can finish 2 candidates, sir. It's okay, sir.
Okay, right, okay. Yeah.
Thank you, sir.
Sir, shall I call the next presenter, sir?
Yeah, please.
Number 22, Dr. K. Maunika.
Yes, ma'am. 1 minute. Am I audible, ma'am?
Yes.
Make it full screen.
My screen. Yes, ma'am. Yes. Good morning, sirs. Good morning, judges. My case report is about a thyroglossal duct cyst, a consideration in adults. Thyroglossal duct cyst is a fibrous cyst that formed from a persistent thyroglossal duct. It is one of the main most common presentation in pediatric midline neck swelling. Although they are present from birth, they are usually symptomatic in early childhood as a mass or a draining sinus. Infection and abscess formations are frequent complication due to the communication between the cyst and the mouth, subsequent contamination by the oral flora. We present a case of 45-year-old male who presented with a newly symptomatic thyroglossal duct cyst. The patient presented to the OPD with slight pain and swelling in the anterior neck, particularly with swallowing. A midline mass was visible and palpable on examination. Subsequent neck exploration reveals a thyroglossal duct cyst filled with brown material. A case history. A 45-year male patient complaining of swelling on the midline in front of the upper part of the neck since the last 2 years. No features of hypothyroidism, hyperthyroidism, or compression. Insidious in onset. Gradually progressive and attains present size. No history of pain, no history of fever, no history of difficulty in swallowing, no history of hoarseness of voice, no history of difficulty in breathing, no history of discharge from the swelling, no history of trauma, no history of previous surgeries. Local examination, ear, nose, and oral cavity examinations are normal. On inspection of swelling, globular swelling in the anterior midline of the neck, 3 into 2 centimeters in size, moves up with the deglutition and protrusion of tongue. Color over the swelling was normal. On palpation, swelling was non-tender, soft in consistency, non-pulsatile, movable below the skin with restricted mobility. Intraoral examination, no swelling present at the base of tongue. No regional lymphadenopathy. Preoperative picture. Differential diagnosis of my case is neck swellings in adults. Midline swellings and lateral midline swellings are inflammatory thyroiditis and non-inflammatory conditions like dermoid cyst, thyroglossal duct cyst, thyroid nodule, thymic cyst, lymphoedema. Lateral swellings are inflammatory and non-inflammatory. Investigations, USG, well-defined cystic lesion with internal echoic and debris noted in the midline. Lower border of the swelling about hyoid bone. Lesions shows wall thickening and vascularity. No perilesional hypervascularity and noted. Normal thyroid gland noted, suggestive of thyroglossal cyst. Preoperative thyroid function test levels are normal. FNAC, there is possibility of thyroglossal duct cyst. Management system cooperation was done. Indications of surgery is cosmosis, malignant degeneration, recurrent infection, and intermittent upper airway obstruction. This surgery includes complete excision of the cyst along with the thyroglossal tract with the removal of a body of the hyoid bone. There were no post-operative complications and no suggestive of malignancy. Histopathology, grossly specimen measured of cystic mass 3.5 into 1 centimeter, midline neck swelling. On cross-section, loculated cyst with thick gel-like grayish brown fluid observed, and microscopically suggestive of a thyroglossal cyst with tract. Discussion, there is a possibility of malignancy in adult cases less than 1%. Most commonly papillary carcinoma followed by squamous cell carcinoma. Treatment in a thyroglossal duct cyst, papillary carcinoma is also a cystine operation followed by evaluation
Last
of
1 minute.
lateral neck lymph nodes. Overall prognosis is 99, survival rate is 99%. Complications of surgery, recurrence and laryngotracheal injury, hypoglossal injury. My conclusion is thyroglossal cyst should be considered as a differential diagnosis in older patient in patients with relative neck masses. Since the differential diagnosis among adults are broader, likelihood of misdiagnosis is greater. Thyroglossal, if not considered as a differential diagnosis, may result in incomplete excision and recurrence. My patient post-op followed up to 6 months, sir. No complication of fistula and recurrence noted, sir. Thank you, sir. These are my references, sir.
Any questions, sir?
Yeah, why body of the hyoid needs to be included in the resection?
Because during development, sir, the thyroglossal tract will be behind, goes behind the body of. There is a curved behind the hyoid bones, body of hyoid. So that if it is not removed, it may leads to recurrence.
Okay. But see, you have to improve the operative pictures. See, you have
Yes.
taken it from a very, it's not informative at all. If I see the specimen is not seen clearly, and the main presentation is the steps of surgery you need to show, no?
Yes.
You have not shown any near, it's like a not very clear pictures actually. But anyway, thank you.
Thank you, sir. Thank you.
This is clinically thyroglossal cyst, and you got an ultrasound done which also shows features of thyroglossal cyst. Then why did you do an FNAC?
In to see any malignant substance or papillary.
Ultrasound shows that thyroglossal cyst. Then why are you suspecting for a malignancy? Not clinically also, it's more confirmative for a thyroglossal cyst.
Yes, sir. Yes, sir.
Right, that's my suggestion for you.
Okay.
Thank you. Otherwise, good presentation.
Thank you, sir. Thank you so much.
Shall I call the next presenter, sir?
Okay.
Number 23, Dr. P.S. Pratyusha. Dr. Pratyusha.
She's not
You are
there.
not audible. You are not audible. Dr. Pratyusha, you are not audible.
Is she there or no?
She's there, sir. She's
there,
not
but
audible,
the
sir.
voice is not coming away.
Ma'am, am I audible now?
Yes,
Yeah,
yes.
increase the volume.
Increase your volume and share your screen.
Increase your Ma'am, is my screen visible now?
Yeah.
Yes.
Go to first slide.
Yes,
Yeah.
Start your presentation.
Yes, ma'am. Good morning, everyone. I'm here to present a case report on parapharyngeal tumor. The parapharyngeal space is an inverted pyramid-like space extending from the base of the skull to the hyoid bone. The tumors in parapharyngeal space, they account for 0.5% of all the head and neck tumors. The parapharyngeal space is important for diversity of the structures it houses and for varied nature of the tumors it can contain. The primary treatment of these parapharyngeal tumors is complete resection, for which various approaches have been described. I would like to present a case of a 45-year-old male patient who came to the ENT OPD with chief complaints of difficulty in swallowing and change in voice in 6 months. The difficulty in swallowing was insidious on onset and gradually progressive. There is no history of difficulty in breathing. There is no history of any comorbidities, no history of any addictions. There was no history of any loss of appetite or no history of any weight loss. Ear examination and nose examination was normal, and on oral examination, there was a mass noted arising from the left pharyngeal wall at the oropharyngeal level, medializing the soft palate and the uvula, and was measuring around 5 into 5 into 6 centimeters. The mass was firm in consistency, it was non-tender and not bleeding on touch, and the overlying mucosa was normal. Neck examination was normal, ultrasound neck was normal. We did an endoscopic examination which revealed a partially obstructed upper airway. Other systemic examination was normal. And the cytology revealed benign neoplasm of the minor salivary glands pleomorphic adenoma. We did a contrast enhanced CT neck, which revealed a 6 into 5 into 5 centimeter well-defined heterogeneous hypodense lesion occupying the left parapharyngeal space. And on MRI contrast neck, there was a lobulated well-defined cystic lesion noted in the parapharyngeal space, which was causing significant narrowing at the narrowing of air column at this level, and it showed a heterogeneous enhancement on IV contrast. Then we planned for a transoral excision of the left parapharyngeal tumor under general anesthesia. Following a fiber optic nasal endoscopic guided nasotracheal intubation was done, and the mouth was opened with a Boyles-Davis mouth gag. Local infiltration was given over the swelling, and a vertical incision was given on the most prominent part of the swelling. And then mucosa and submucosa and constrictor muscles were divided. Once the plane was reached, a blunt dissection was done using a ribbon gauze. The tumor was mobilized medially, and the dissection was continued in all the directions, and bipolar cautery was used to achieve the hemostasis. The wound was irrigated, and a hemostasis was achieved, and the wound was packed with Surgiflow. And the abgel was placed, and the wound was finally closed with Vicryl. Here is the specimen showing the parapharyngeal tumor. It was measuring around 5 into 5 centimeter and was well encapsulated, and the specimen was sent for histopathological examination. Post-operatively, the patient was kept nil by mouth for 10 days, and Ryle's tube feeding was given, and the patient resumed oral feeds prior to the discharge. Here is the post-operative image of after resection of the tumor on the day 10 and day 30 of the post-surgery. The histopathological report was suggestive of pleomorphic adenoma, a benign salivary gland tumor. Discussion being the parapharyngeal space is a potential space in the deep cervical fascia and is divided into pre-styloid and post-styloid compartments by the facial condensation connecting the styloid process to the tensor veli palatini. The pre-styloid compartment houses the adipose tissue, minor salivary glands, lymphatics, and the branches of fifth nerve and the deep parotid gland. The post-styloid compartment houses important vital structures such as carotid artery, jugular vein, cranial nerve 9th to 12th, and sympathetic chain. Coming to the discussion, salivary gland tumors are the most common tumors seen in the parapharyngeal space, followed by the neurogenic lesions. Pleomorphic adenoma is most common. CT and MRI are useful tools for investigating the tumor's host interface and involvement of important neurovascular structures. Many approaches were described. Transcervical and transoral approach is most common. Choice of the surgical approach is based on the tumor size, location, histopathology, vascularity, and the relationship to the critical neurovascular structures. Transcervical is the most common, provides adequate exposure and control of blood vessels, but there is restricted exposure to the medial and superior aspect and longer hospitalization stay. Transoral is preferred because of superior vision, good cosmetic and functional outcome, and the cons being limited surgical space. In our case, despite having a larger parapharyngeal tumor, location in the pre-styloid compartment, absence of trismus, no comorbidities made him a suitable candidate for transoral approach of the tumor excision. Conclusion being the transoral approach for parapharyngeal tumors has been criticized because of the increased rate of vascular and nerve injuries and poorer visualization. However, the transoral approach reduces the overall morbidity while providing the direct access. A careful assessment of the patient as well as the tumor is required before surgery so that transcervical incision or mandibulotomy can be avoided. These are my references. Thank you, sir.
Hello.
Sir.
Why did you keep the patient nilorally for 10 days?
So Ryle's tube feeding was given and the surgical wound was there in the oral cavity. So to avoid the infection, we kept nil by mouth and
Usually
give a Ryle's tube feed.
this incision what you are given will heal in 5 days, 6 days time maximum.
Okay, sir.
Why 10 days? Any this one?
Nothing, sir. We kept him for 8 to 10 days nil by mouth, sir. We started him on oral liquids on the 8th post-operative day, and the patient resumed soft diets from 10th day onwards.
Okay.
Thank you, sir.
Thank you, sir. This is the end of first session. Thank you, Somo Lakshmanan, sir, and Prakash Reducer, sir, being here as judges, and thank you, Dr. Indra Devi, madam, as a chairperson. We will move on to next session, sir.
Ramesh,
yeah. Sir.
We'll stop here and go.
Yeah, you can.
We'll send the results, whatever is there, by WhatsApp to you.
Thank you so much, sir. Thank you.
Thank you, Ramesh, sir, and all the best for all the participants. They all did very well.
Yeah, thank you so much, sir.
I congratulate everybody. They have done well. And Dr. Soma, it's nice meeting you.
Thank you, sir. Thank you, sir. Yeah.
And I heard about you, but it's the first time I'm seeing you. I heard about you lots of things that you are doing very good work in your place. Thank you very much. And thank you, Harsha. Bye.
Thank you.
Thank
All the best, colleague.
Thank you, sir. Yes, sir.
Ramesh?
Welcome, sir.
Ramesh?
Ma'am, Indra
Yeah,
ma'am.
thank you very much. Harsha, congrats once again. Well organized as usual.
Yeah.
So thank you very much. Even the judges were very good, despite so many problems like internet and audio problems.
Yes.
Well organized. Thank you very much. Yeah.
Thank you so much, madam. Now I will call upon hearty welcome to Dr. Bharati madam, our AOI National President, and Dr. Prabhakar sir, my teacher and Associate Professor of Andhra Medical College. For this session, they are the judges, and I welcome Dr. Durga Prasad sir for this session as a chairperson. Dr. Harsha, please read out the CV of Dr. Bharati madam.
Thank you, sir. I would like to introduce Dr. Bharti madam. She is the professor and former HOD in the Department of ENT, JSS Medical College, with an overall teaching experience of 33 years. She has done as MBBS and MS from Bangalore Medical College and Research Institute, and followed by DNB in the prestigious All India Institute of Medical Sciences, New Delhi. She has also trained and received fellowship in head and neck oncology and mini fellowship at Pier Antony Hospital, Italy, where she has been awarded gold and silver medals respectively. To her credit, she has various publications in national and international journals, and her specific area of interest is OSA, upper airway and head and neck oncology. Right now, she is serving as the president of Association of Otolaryngologists, India. Welcome, ma'am. We are deeply honored to have you on our virtual case presentations.
Thank you, Harsha, and welcome, ma'am. And then Dr. Prabhakar sir, CV.
I would also like to invite the second judge for the day, Professor M. Prabhakar sir. He is Associate Professor in the Department of ENT, Andhra Medical College, Visakhapatnam. He has done his MBBS from KMC Warangal and MS from Gandhi Medical College, Hyderabad. He has worked previously in KIMS Narketpalli, RIMS Adilabad and RIMS Srikakulam in various capacities as assistant associate and also as a deputy medical superintendent. His areas of interest is head and neck oncology, rhinology, otology and skull base. Welcome, Prabhakar sir. We are indeed happy to have you on our presentation.
Thank you, Harsha. So judges, shall we proceed?
Yeah, Dr. Ramesh. Yeah. How many students we have now in this session?
Sir, this is final 20, sir. 20. Probably 20 minutes, less than 20 only, ma'am.
And the time limit?
Time is the 5 minutes, ma'am. This is a case report. They have to be 4 to 4 minutes. If they finish, you can ask the questions, ma'am. If they cross the 5 minutes, no questions allowed, ma'am.
Will be asked.
Yes. Thank you, ma'am. Manoj?
Sir.
Any leftover cases below 20?
Yes,
call.
sir. Actually, few of them are offline. Shall I call their names, sir?
No. If they are in the online, then only call them. Otherwise, you can start the serial number, whatever they have stopped. 23. Okay, after 23, you can start now.
Okay, sir.
Meanwhile, you call personally, and we will arrange in the last session. At the end of the session, we will arrange for them.
Okay, sir.
Thank you.
I call upon Dr. Vrinda Ullas Nair.
Sir, Vrinda is unwell, sir. She won't be presenting. Hello.
Dr. Vrinda Ullas Nair, number 24.
Vrinda is unwell, ma'am. She won't be able to present.
Okay. Next candidate.
Number 24, Dr. Vrinda Ullas Nair.
Next candidate. Call next candidate. Vrinda is not well. No.
Number 25, Dr. Haripriya JN.
Yes, ma'am. Am I audible, ma'am?
Yes. Share your screen.
Okay, ma'am.
Yeah, tell her serial number. Every time judges will know
Number
that.
25, sir.
25? Yeah.
Yes, sir.
Thank you.
Is it visible, ma'am?
Yes. Start your presentation.
Okay, ma'am. Good morning all. My presentation is dentigerous cyst associated with the maxillary premolar. A 9-year-old boy presented with a left side cheek swelling from 1 month, which was insidious in onset, initially small size and gradually progressed to present size. There is no history of trauma to face, no history of pain or decreased perception of sensation over the left side of the face, no history of headache, cold, sneezing or fever. Past history, not significant. Family history and personal history is not significant. On general examination, patient is conscious and cooperative, oriented in time, place, and person. There is no pallor, icterus, clubbing, cyanosis, pedal edema, lymphadenopathy, skin, hair, nail normal. Vitals, temperature, febrile, pulse rate 88 per minute, blood pressure 110/70 mm mercury. Systemic examination, cardiovascular system, S1, S2 heard, no murmur. Respiratory system, bilateral air entry present, no added sound. Central nervous system, no focal neurological deficit. On local examination, inspection, a single diffuse swelling on left side maxillary region is present. Skin over the swelling is normal, no visible pulsation, scar, or sinuses. On palpation, all inspectory findings are consistent with palpation, no local rise of temperature, non-tender. Swelling is situated in the left maxillary region, which has got smooth surface, ill-defined margin, hard in consistency, and is non-mobile. Oral cavity, oropharynx normal, nose, anterior posterior rhinoscopy normal, ears normal, examination of neck normal. Management, investigation, routine investigations are normal. CT-PNS shows an expansile, well-defined lytic lesion measuring approximately 6 into 4 cm in the left side of maxillary ridge and protruding into left maxillary sinus, an unerupted tooth noted projecting within the left maxillary antrum, impression of dentigerous cyst. Treatment, we done enucleation and extraction of the associated tooth by a Cadwell loop procedure under general anesthesia. These are the surgical procedure we done. The sample sent for histopathological examination came as non-keratinized stratified squamous epithelium with a surrounding wall of thin connective tissue containing odontogenic epithelial rust. Discussion. Dentigerous cysts represent the second common odontogenic cyst. Dentigerous cysts formed by the expansion of the dental follicle, the soft tissue covering the crown of an unerupted tooth, and are attached to the cemento-enamel junction. It accounts for 15 to 80% of jaw cyst. 70% of dentigerous cysts occur in the mandible and 30% in the maxilla. The teeth commonly affected are mandibular third molar, maxillary canine, mandibular second molar, maxillary third molar. The peak age of presentation, second to third decade of life or later adulthood. More prevalent in males. The exact histiogenesis of dentigerous cyst is unknown, but it stated that dentigerous cyst developed by pressure applied by the emerging tooth on a dental sac which blocks the venous flow, causing a serum to pass through the capillary wall. This accumulated fluid exerts increasing hydrostatic pressure and detaches the dental arc from the crown of the tooth. Second is the inflammatory origin, which Bloch suggested that the origin of dentigerous cyst is overlying deciduous tooth that resultant periapical inflammation will spread to involve the follicle of the unerupted teeth, inflammatory exudate resulting in cyst formation. So the enlargement of dentigerous cyst associated with the proliferation of epithelial cells, release of bone-resorbing factors, osmolality of the fluid within the cyst. The dentigerous cysts in the maxillary sinus are easy to detect radiographically due to their opacity. Early cysts in the maxillary sinus may displace and obliterate the maxillary antrum and nasal cavity. Ectopic eruption of the tooth in the maxillary sinus is rare, may be due to the development disturbances, pathological process, and iatrogenic activity. Marsupialization of the cyst is a treatment of choice in children in order to give a chance to the unerupted tooth to erupt. If the tooth was displaced up to the roof of the maxillary sinus from the alveolar arc, enucleation with the removal of the displaced tooth was favored. Disadvantage.
Last 1 minute.
Disadvantage of marsupialization is that the pathological tissue is left in situ and there is a possibility of more aggressive lesion in the residual tissue. If left untreated, dentigerous cyst can cause pathological bone fracture, secondary infection, impaction of the teeth, asymmetry, ameloblastoma, squamous cell carcinoma, and mucoepidermal carcinoma. Recurrence rate of 12 to 14%. These are the differential diagnosis. Can be a univocal ameloblastoma, keratocystic odontogenic tumor, calcifying epithelial odontogenic tumor, adenomatoid odontogenic tumor. Conclusion. Early diagnosis and treatment of odontogenic cyst is important to prevent the morbidity. Radiological and histopathological findings helps in diagnosis, and if left untreated, it has a tendency to transform into a tumor. Thank you.
Any questions, sir?
Time is there, or I think we can go all 5 minutes over, I think, no? Hello.
Shall I call the next presenter, ma'am?
Yeah.
Yes, yes.
Number 26, Dr. J. Mohana.
Yes, ma'am.
Can I know your name, madam?
Dr. Mohana?
No,
Yes,
not
ma'am.
her name. Your name?
Dr. Mohana?
Yes, yes, I'm sharing my screen, ma'am. Can you see, ma'am? Can you see my screen?
Yes, yes.
Can you see it changing?
No.
Now?
Yes.
Yeah.
Increase your volume.
Okay, ma'am. Okay, ma'am. Now, ma'am?
Yes, yes.
Yeah. Can I start?
Start your presentation.
Yeah.
Yes,
Good,
yes.
good morning. Good morning, ma'am. I'm Dr. Mohana. I'll be presenting a case of maxillary schwannoma. Schwannomas are benign neoplasms of the peripheral nerve sheath. The head and neck region is the commonest site for such benign nerve sheath neoplasms. They constitute for about 20 to 45% of the head and neck tumors, and there is significant morbidity depending on the site of the origin. They commonly arise from the roots of the cranial nerves and the cervical sympathetic plexus in the parapharyngeal space, and majority originating from the vagus nerve. They can also be originating from the fifth cranial nerve, from the root to the distal extracranial branches, and it in majority it arises from the Gasserian ganglia in the middle cranial fossa. Of the patient this is an 80-year-old female patient presented with the complaints of right nasal obstruction for a period of 9 months and headache for a period of 4 months. Patient had a gradually progressive partial nasal obstruction for a duration of 9 months associated with mucosal. I have changed my. Can you see?
Yeah, now we can say.
Yeah, associated with mucoid non-blood-stained discharge. There's complaints of difficulty in opening mouth, left-sided diffuse headache, and numbness over the right side of the face. The patient has no history of epistaxis, anosmia, bouts of sneezing, double vision or decreased vision, no history of vomiting, tooth pain, dysphagia, trauma, or radiation exposure, no other comorbidities, no previous surgeries, or no addiction. On the examination, the external nose was normal. There was decreased nasal patency. An anterior rhinoscopy, a pale nasal mass was seen in the right nasal cavity near the middle meatus region. It was insensitive to touch and not bleeding on touch. There was tenderness in the right ethmoid sinus region. Decreased sensations of the right of the face. Visual and extraocular movements were normal. All other examinations were normal. On investigation on diagnostic nasal endoscopy, a pale mass, mucosa covered mass seen in the middle meatus region between the septum and the lateral nasal wall. The subject of the patient radiology on CT scan, we saw a
Change your
basic
slide change.
I have changed. Can you see now,
Mohana,
ma'am?
your slides are not changing. Wow.
One second. Now, ma'am, can you see the slide?
No. Your video you can close so that if at all the net connectivity problem is there.
1 second, ma'am. You can't see my screen now.
No,
Now,
examination of nasal. Yeah. Now in the
Now
small form.
Okay. Ma'am, time just now, ma'am. Can you see?
Yeah, we can see.
Yeah, on CT scan, there is a homogeneous opacity in the right nasal cavity extending with a peripheral calcification extending from the pterygopalatine fossa up to the foramen rotundum and medially in the right ethmoid sinuses and up to the posterior end of the turbinate. On MRI scan, there is on T1 weighted images, there on T2 weighted images, there is enhancing lesion again in the pterygopalatine fossa extending up to the foramen rotundum laterally. Medially, it is built up to the ethmoid sinus. Management, we did an open approach by a Weber-Ferguson incision and right maxillary swing technique. This is the Weber-Ferguson incision. This is the fast case subperiosteally. Then we
change the slide.
Now, ma'am.
No. No.
Can you see now?
No.
Are you?
Yeah.
Now can you see? Okay, ma'am. We gave a Weber-Ferguson incision, then subperiosteal planes were elevated. We gave an osteotomy laterally over the zygoma medially over the pyriform aperture, then between the incisors and the palate incision was given. It went up laterally to up to the maxillary tuberosity. The maxilla was literally opened, and we could see the posterior wall of the maxilla. It was removed, and the pterygopalatine fossa, there was a mass visualized. The entire mass was excised. It was extending into the sphenoid sinus and ethmoids. That as well was removed. Then after removal, the sample was sent for histopathology. The wound closure was done in layers. On histopathology, it showed its conclusion was a schwannoma. It showed antennae A areas and B areas, hypercellular and hypocellular areas with nuclear palisading called verrucate bodies. Conclusion was schwannoma. Discussion: schwannoma is a benign slow glowing the cranial nerves, except for the first and the second nerve. It can, in the parapharyngeal region, it can arise from the lower cranial nerves or the trigeminal nerve commonly. On the retromaxillary and pterygomandibular region, it is most likely it can become malignant. Conclusion: many approaches are described for the pterygopalatine fossa tumors extracranially via skull-based transmaxillary intratemporal. We did a transmaxillary approach. An open approach is reliable because tumors, because it is an inactive area and we need complete removal of the tumor. That is why we underwent an open approach. These are my references. Thank you. Ma'am?
Any questions, ma'am?
Okay. Yeah, your time is over. But anyhow, how do you differentiate between schwannoma and neurilemoma?
It was a histopathological diagnosis, ma'am. It has a well encapsulated tumor. These antennae A areas and antennae B areas mainly, ma'am.
Then anything else? If at all we send for immunohistochemistry, what will be positive for schwannoma? What will be negative for neurilemoma?
Schwannoma, I'm not sure, ma'am. But
okay, and which is good to have, schwannoma or neurilemoma?
Ma'am, schwannoma is benign, ma'am. Schwannoma complete removal is
because it arises from the Schwann cell. You can remove it without sacrificing the nerve of origin.
No, yes,
isn't it?
Yes, ma'am. It has better prognosis. Yes, ma'am.
Okay, then.
Thank you, ma'am. S100, is it right?
Yeah.
Right, I can. Yes.
Okay,
thank you.
Next presenter, Dr. A. Srujana. Number 27.
Am I audible?
Dr. A. Srujana.
Am I audible, sir?
Yes, you are audible. Share your screen.
Is my screen visible, sir?
Yeah, make it full screen.
Is it okay, sir?
Okay.
Srujana, before you start, I'll tell you one thing. If at all your slides are not moving or there is some connectivity problem, you switch off your video. Go on just presenting the slides, okay?
Okay, ma'am.
Yeah.
Okay, ma'am. Good morning, ma'am. Good morning, everyone. I'm going to present the case report on
Enlarge karo, full screen karo.
Is it okay now, ma'am?
Yes, it's okay. Please go ahead.
Introduction. A mucosal of paranasal sinus is an accumulation of mucoid secretion and dispermated epithelium within the sinus with distension of its walls. And a mucosal is formed when drainage of mucus from one of the paranasal sinuses are blocked by either by obstruction of its ostium and inflammation. And the occlusion can be secondary to any congenital anomalies or allergy, scarring, polyp, trauma, anatomic abnormality, or any previous surgeries. The mucosals are usually seen in frontal, followed by anterior ethmoid and maxillary sinuses. Posterior ethmoid and sphenoid sinuses are rarely involved. Mucosals extend into surrounding tissues by eroding the sinus walls and causing pressure effect. Diagnosis is based on clinical investigation connected with the aid of CT and MRI. Mucosals, they are usually treated by either endoscopic or external approach depending on the location and extent. So I hereby report a case of 30-year-old female with a mucosal of ethmoid sinus with orbital extension illustrated with CT and endoscopic images. She was successfully treated with endoscopic approach. A 30-year-old female presented with swelling around the left eye since 18 months, which was gradually progressing in size. And the swelling was also associated with excessive watery discharge and pain in the left frontal region. There was intermittent history of left nasal obstruction.
There was no history of diplopia or decreased vision. Past history, she underwent nasal surgery, that is functional endoscopic sinus surgery 6 years back. And she had no history of trauma to eye or nose. Personal and family history is not significant. On physical examination, there was a soft fluctuant non-pulsatile swelling present in superomedial quadrant of left eye. There was mechanical ptosis due to swelling and eyeball was pushed downwards and lateral. There was no conjunctival hyperemia. Vision was normal in left eye with full extraocular movements in all directions except in superomedial direction. Pupillary reaction was normal. General and systemic examination was normal. On local examination of nose, anterior rhinoscopy, a deviation of septum towards left with basal spur was noted. Bilateral ears and throat examination was normal. On diagnostic nasal endoscopy, we confirmed the deviated nasal septum to left with the basal spur impinging on inferior turbinate, and a large cystic swelling was visualized in middle meatus of left nasal cavity. Crust were present. No discharge or polyps was seen. Covena was normal. Right nasal cavity was also normal. On investigation, CT scan showed an expansive cystic mass of size 3.5 into 2 centimeters in left anterior ethmoid sinus region, which is extending into extracorneal compartment of left orbit, compressing the left medial rectus and thereby producing proptosis. And there was also seen erosion of lamina patricia on the left side. The lesion is seen extending up to frontal sinus and also seen causing blockade of nasolacrimal duct. The patient underwent endoscopic excision of mucosal. The operation started with uncinectomy and a whitish bony shell of mucosal was noticed. On incision, yellowish thick mucus was escaped from the mucosal cavity, which was suctioned. And thereafter, frontal ethmoid sinuses are opened carefully under endoscopic guidance. Medicated nasal packing was kept, which was removed the next day. Nasal dosing was done regularly for the next 1 week, along with intravenous antibiotics. By the end of the first week post-operatively, the swelling was gradually reduced and the eyeball returned back to completely normal position and patient was discharged. Regular follow-up was done in ENT OPD with no fresh complaints. Discussion. Mucosals are benign, slow-growing cystic lesions developing secondary to obstruction of sinus ostium. They commonly occur in the frontal or ethmoidal group of sinuses and are rarely found as an isolated intranasal lesion. They usually manifest clinical symptoms by eroding the bones of the sinus wall and thereby causing pressure effect. The diagnosis of mucosal is based
Last
on
1 minute.
Diagnosis of mucosal is based on a history, physical examination, and radiological findings. The clinical presentation of mucosal varies with the anatomical site. So, due to anatomical proximity, orbital symptoms are frequently encountered, proptosis and diplopia being the most common complaints. The classic radiographic appearance is generalized thinning and expansion of sinus wall as well as bony erosion and destruction of sinus wall. CT is preferred. The three criteria for CT diagnosis are homogeneous isodense mass, clearly defined margin, patchy osteolysis around the mass. On MRI, mucosals tend to be bright on T1 weighted images compared to brain isohyperintense on T2, which is pathognomic MRI finding for mucosals. So on differential diagnosis, we may consider dermoid cyst, histiocytosis, fungal and TB infection, cholesterol granuloma, or any other uncommon neoplasms. The treatment is basically surgical. The goal is to drain the mucosal and ventilate the sinus along with prevention of any recurrences. And the surgical approach is based on size, location, and extent of mucosal. They are treated surgically either with external or endoscopic approach.
Your time is up. Ma'am, shall I call the next presenter?
You can call. Once the time
Yeah, you
up,
can
you
call.
can call.
Number
Actually, you should
28.
maintain the time.
Yeah, madam, if they finish within the time only, you can ask the question. Madam.
Yeah, that's what I told her. You should maintain the time. We
Yes,
can
sir.
call the next.
Number 28, Dr. Farha Tunia.
Good morning, everyone.
Dr. Farha.
Yes, am I audible?
Increase your volume.
Okay, am I audible now?
Yes, share your screen, please.
Is it visible?
No.
Now is it visible, ma'am?
No, it is not
No,
visible.
not yet.
Yeah.
Start your presentation.
Okay, today I'm going to present a case about third branchial arch fistula. The branchial arch fistula is an uncommon anomaly of embryonic development of branchial apparatus. Among these anomalies, second branchial arch is well known and it is most common. Third branchial arch anomalies are less common comparatively. The branchial fistula results from the breakdown of the endodome, usually in the second pouch. In the normal course, a persistent fistula of second branchial cleft and pouch passes from the external opening which is present in the mid or lower third of the neck in the line which is present anterior at the anterior border of the sternocleidomastoid muscle, which is deep to the platysma and carotid sheath. The tract then passes medially between the internal and external carotid sheaths, in our case after crossing glossopharyngeal and hypoglossal nerves as well. Although branchial fistula may occur at any age, but commonly they may present in first and second decade of life. So our patient's name was Malay. She was 35 years old. He was residing at Shankarpalli. Occupation, he was a salesman. He presented to OPD with complaints of swelling in the left side of the neck, which he noticed 5 days, since past 5 days, associated with pain and discharge from the sides in 3 days. Patient was apparently asymptomatic 5 days back. Then he developed swelling on the left lower side of the neck, which was insidious in onset, gradually progressive in nature, no aggravating factors, but it was relieved on medication. Swelling is associated with discharge. We started 3 days after the swelling. Discharge is insidious in onset, intermittent, yellow in color, mucoid in consistency. There is no aggravating factors, but it was also relieved on medications. There was pain which was insidious in onset, progressive, but no aggravating. The pain was also subsiding on taking medication. There is no history of fever, weight loss, night sweats, or loss of appetite. No history of any difficulty swallowing, difficulty breathing, or change in voice. Patient had similar episodes since childhood, 5 to 7 episodes per year until now. The swelling always healed with a scar. History of previous incision and drainage was also done in the year 2017 and 18. He is not a known case of any thyroid disorder. He is not known case of any chronic comorbidities. Family history is not significant. Personal history: diet mixed, appetite normal, sleep adequate, bowel and bladder regular. There are no addictions. General examination: patient conscious, coherent, cooperative, well oriented to time, place and person. No pallor, icterus, cyanosis, clubbing, lymphadenopathy. Apart from that, his systemic examination vitals were stable on CVS, S1, S2 heard, respiratory normal, vesicular breath sounds were heard, CNS, there was no mental functions, everything was normal, upper abdomen soft, non-tender, no organomegaly was noted. General examination, ear was normal, Rennie's, Weber's, absolute bone connection, everything was normal. Oral cavity was also normal. Neck examination, swelling. Inspection, it was noted on the single globular swelling was noted on the left lower side of the neck, which was approximately 4 to 3 centimeters in size. It had irregular margins and there was a scar which was seen. The surrounding skin was normal. On palpation, inspecting findings were confirmed. The temperature was warm, consistency was firm, and tenderness was present. It was not fixed to any underlying skin. It was not fixed to skin or underlying structures. Regional lymph nodes were not palpable. So provisional diagnosis for my case is fistula or sinus of the branchial arch. Differential diagnosis includes lymphadenopathy, hemangioma, carotid body tumor or tuberculosis, parapharyngeal swelling, lymphangioma. Investigations which were done for our case was branchial anomalies usually suspected for any late or recurrent masses which are present in the neck. So what we are supposed to do, we did certain blood investigations such as CBP, BT-CT, LFT, ECG, Mantoux, chest X-ray, ultrasound, CT, MRI, FNAC and fistulogram was done, which was specific for the case. CT showed...
Last 1 minute.
Okay. CT scan of the neck shows a linear hypodense area which was noted in measuring about 9.2 millimeters in the left lateral wall of the laryngopharynx, which was just posterior inferior to the hyoid bone with ill-defined hypodense collection surrounding the lesion and extending along the lateral wall of the left laryngopharynx with obliteration of the left piriform sinus. Small hyperdense focus was also noted within the soft tissue at the level of hyoid bone, measuring 7 by 4.4 millimeters. MRI was also done. It was T1, T2, axial and coronal sagittal sections was also. This showed there was a small linear to curvilinear hypo-intense focus in the subcutaneous planes of soft tissues of the neck in the anterior aspect on the left side. So, small soft tissue collection is noted in around the hypodense focus, which is tracking anterior inferiorly, which is anteromedial in relation to the left sternocleidomastoid muscle, with a small posterior medial tract, which is ending close to the anterior aspect of the left longus colli muscle and in the left carotid space. This is a fistulogram which was done.
Doctor, your time is up.
Okay. Thank you.
Farhad, you should know how to make your slides, Farhad. You cannot overdo it. Only one image you select, not the entire CT scan, entire thing. One image and you present. Okay.
This is the video of the.
Okay, no problem.
No,
Time is up
no,
now.
next candidate.
Yeah.
Okay.
You can stop your presentation. Next candidate, Yunus Fatima. Dr. Yunus Fatima. Dr. Yunus Fatima. I'm calling the next one. Dr. K. Shilparani.
Serial number.
Number 30. Dr. K. Shilparani. Dr. K. Shilparani, number 30. I'm calling the next candidate, number 31, Dr. Insha Javed.
Sir. Sir, am I audible, sir?
Yeah. You are Dr. Insha Javed.
Yes, sir. 31. Insha Javed.
Yeah, start your presentation.
Okay.
Start.
It's visible, sir.
Yes, it is visible.
Yeah, you can start.
Okay. Good morning, everyone. I am going to present the case report on pituitary adenoma. Moving with the introduction, it's a pituitary gland. As we all know, it's located in the sella turcica at the base of the skull. As an ENT surgeon, we can approach to this and the various tumors can be approached through the various approaches, which I'm going to present in this case presentation. Most of the adenomas in pituitary are the microadenoma and macroadenoma, which is based on the size, which less than 1 is called as microadenoma and more than 1 centimeter of size is called as macroadenoma. The incidence of microadenoma is more than the macroadenoma, and there is another classification for adenomas can be a secretory type or the non-secretory type. Secretory type being the 5 times more than the non-functional adenomas. Transsphenoidal access to the pituitary gland is the most common approach for the pituitary adenomas. The different routes to sella can be a transsphenoidal, transnasal, transceptor. It could be a microscopic approach or endoscopic, but ultimate goal is to reach the sinus, sphenoid sinus to reach the sella. The anatomical variation of the sphenoid sinus is to be known by the surgeon to decrease the complication and assess the surgical access easily. Moving with the case history, 37-year-old male presented to ENT OPD with decreased vision 3 years and headache for 1 year. Patient complaints start with decreased right eye vision, insidious onset, gradually progressing. With span of 1 year, it progressed to left eye, not associated with any redness, protrusion of eye. There is no history of headache or there is no history of any trauma or to head or eye. Headache was insidious in onset, progressive, pronounced on left frontal region, throbbing type, intermittent, aggravated on coughing and bending forward. Patient has a history of loss of weight, cold intolerance, constipation, dry skin, fatigue, and excess daytime sleepiness. History of delayed secondary sexual characteristic present. History of erectile dysfunction and galactoria present. There is no history of polyuria, polydipsia, or any walking difficulty or hand movement difficulty, loss of consciousness and convulsion. There is no history of any ENT complaints. Moving with the examination. Patient was average build, short statured, with central obesity, normal gait, pallor present, vital stable. Eye examination revealed that pupil was 2 mm
both side and anterior segment of the both eye normal. Right eye perception of light was absent, and left eye hand movement can be perceived. Pupillary reflex, ipsilateral and consensual was intact on the both eyes. Ocular movements, both eyes are normal. Cranial nerve are normal. ENT examination normal, and transnasal endoscopy is normal. Moving with the specific investigation, visual field defect done by the perimetry. In right eye, we couldn't perform this test because the perception of light was absent. And the left eye, we shows that the temporal hemianopia. The picture showing the same of the patient. The fundus examination of the patient shows that the bilateral disc was pale. Moving the hormonal profile of the patient, the serum prolactin was the 2200 nanogram per deciliter, which is way high. So, being the male, normal range is 20 nanogram per deciliter, which is this indicated there is a high level of prolactin, which could be a prolactinoma. And all other hormone, TSH, T3, FSH, LH, testosterone, growth hormonal, are all other hormones are less in level as compared to the normal range, showing that the patient has a panhypopituitarism. Differential diagnosis on the basis of this history. It could be a pituitary adenoma, craniopharyngioma, Redcase cleft cyst, meningioma, pituitary neoplasm, or chordoma. MRI of the patient of mine shows that there is a homogeneous mass, as we can see in the sagittal section of the MRI, which is extending in the cella and extending to the suprasellar region, intending on the midbrain and the third ventricle. Moving with the coronal view of the same patient, shows that there is an internal carotid artery can be visualized on the bilateral side in the cavernous sinus. It shows that there is a least likely to be an invasion in the cavernous sinus by the tumor. So according to this Wilson grading, which is based on the extracellular extension, it could be a grade 4. Moving on the transsphenoidal approach, which we did for the tumor resection, we did endoscopic transnasal transsphenoidal approach surgery was done. Patient in general anesthesia. Endoscope was navigated in nasal cavity to reach the sphenoid flow. Sphenoidectomy was done. A large opening was made in both posterior nasal septum and anterior sphenoidal wall with the help of drill. And inside the sphenoid sinus, we localized the sella turcica and optic carotid recess. Anterior wall and the floor of the sella turcica was open, dura open, and the tumor was removed. The closure was done with the facial lata, abdominal fat, and fibrin glue, as we can see in this picture. And Hadad flap were harvested and the placed finally over the graft. There is no intra-op CSF leak was detected. Histopath examination of the same is confirming the same pituitary adenoma.
Dr. Insha, your time is up.
So should I
Stop your presentation. Yeah, and the next candidate, Dr. N. Srileka.
I extend the time.
Next candidate, Dr. N. Srileka. Number 32, Dr. N. Srileka. Calling the next one. Number 33, Dr. Nazima Begum.
Hello.
Yeah.
Good afternoon, sir.
Good afternoon. Are you Nazima Begum?
Yes, sir.
Yeah. Share your screen.
Sir, is it visible, sir?
Yes, it's visible.
Okay, ma'am. My name is Dr. Nazima, and my topic for today is the unusual sinonasal malignancy in a young individual, especially the sphenoid sinus malignancy. So, so 1 second, sir. My screen is giving a bit problem. I am unable to see.
Start from the first slide.
I mean, I'm seeing this grid view also on my screen, sir. I'm unable to read also.
We are able to see your slides.
Yes, sir. I mean, I'm unable to see the slide completely. How should I move it down, sir?
You reduce the zoom so that you can view.
Okay, sir. Sir, can you give me some time, sir?
Okay.
We'll
I'm
call
calling
the next
the
candidate
next
then.
presenter.
Okay, sir. 1 second.
Yes. Stop your screen sharing. The next candidate, Dr. M.V. Sripriya.
Sir, is my screen visible, sir?
Increase your volume.
Increase your
Is my
volume.
screen visible, sir?
Yeah, screen is visible. You increase your volume.
Make it full screen.
Yes, sir.
Yeah.
Good morning, everyone. My case is a combination of atresia coina, coloboma, cleft lip, which is likely to be CHAD syndrome. A 7-year-old male child has been brought to a ENT OPD with right side nasal obstruction and right side nasal discharge since birth. Right side nasal obstruction, which is non-progressive, continuous, and no aggravating or relieving factors. Right side nasal discharge, which is mucoid, occasionally mucopurulent, with a past history of cleft lip repair under general anesthesia at 1 year of age. Birth history: it is a first order child with third degree consanguineous parents, born by cesarean section with a birth weight of 2.25 kgs, cried immediately after birth and no NICU admissions, with normal history of growth and development and good school performance. On examination, the child is alert and active, height above 3rd percentile with normal vitals. Systemic examination is normal with normal external genitalia. This scar of repaired cleft lip right side. And ophthalmology expert opinion shows coloboma of right lower eyelid with normal visual acuity in both eyes. Nose examination on anterior rhinoscopy, septum is in midline, right nasal cavity shows mucoid discharge, left nasal cavity is normal, cold spatula test shows no misformation on right side, and cotton wool test no movement on right side. On posterior rhinoscopy, right side coinal atresia is seen. Ear examination is normal, Rennie's test is positive both ears. Weber's test equally heard on both sides. Oral cavity, oropharynx and cranial nerve examination is normal. Investigations: diagnostic nasal endoscopy. This shows right side eustachian tube and coina could not be seen, as endoscope could not be advanced posteriorly because of this obstruction. And CTPNS shows mixer type of right unilateral coinal atresia, which confirms the diagnosis of unilateral coinal atresia. Pure tone audiometry shows normal hearing. Ultrasound abdomen and echocardiogram shows no abnormality in this child. My provisional diagnosis is right unilateral mixer type of coinal atresia, coloboma of right lower eyelid, and repaired cleft lip right side. This patient has been treated with right side transnasal endoscopic drilling and stenting under general anesthesia. Procedure: using a 0-degree transnasal endoscope, microdrill, and 3.5 mm endotracheal tube used as stent, sutured circumceptally with 1 proline. It has been left in situ for 6 weeks. Child has been followed up every week to look for patency of the stent and columella necrosis. After 6 weeks, stent has been removed under general anesthesia and granulation tissue has been removed. This child has been followed up every 15 days. This shows a post-op image at 3 months showing neocoina. Discussion: CHAD syndrome, it is an autosomal dominant genetic disorder due to mutation chromodomine helicase DNA binding protein CHT7 located on chromosome 8. Pagan et al. In 1981 coined the acronym CHARGE, which accounts for coloboma, heart anomalies, atresia coina, retardation of growth and development, genital abnormalities, and ear abnormalities as non-random associations, which are present in varying combinations and to varying degrees in individuals with CHAD syndrome. It has been redefined in 1998 as major, minor, and occasional criteria. Out of these, 2 major criteria, that is ocular coloboma and coinal atresia, and 1 minor criteria, cleft lip, is present in our case. Coinal atresia is nothing but persistence of nasobuccal membrane, which usually ruptures at 5th to 6th week of intrauterine life or due to abnormal neural crest migration. This is a rare condition which presents 1 in 7,000 live births. Female is to male ratio is 2:1, and our patient is a male child. It has 3 types: bony, membranous, and mixed. Unilateral, which is in 65% and occurs later in life with nasal obstruction and nasal discharge. Bilateral is 35%, presents as acute respiratory emergency at birth as newborns are obligate nasal breathers, and our case is a mixed and unilateral type. Conclusion: This case, right unilateral coinal atresia, coloboma of right lower eyelid, and repaired cleft lip right side with third-degree consanguineous parents, shows association with CHAD syndrome. So, any patient with any unilateral nasal obstruction and nasal discharge, coinal atresia should be considered as differential diagnosis, and coinal atresia should be evaluated for other heart, eye, ear, and cranial nerve anomalies. Thank you.
Any questions, ma'am?
Did your patient had any hearing problem?
No, ma'am.
Did you evaluate? How did you evaluate, if at all?
Normally in OPD, Rini and Weber test, ma'am, and as
What's the
investigation.
age of your patient? What is the age of your patient?
7 years male child, ma'am.
Okay. Then what are the investigations?
We did pure tone audiometry, ma'am. Patient was cooperative, so that was enough for us.
Okay, if at all the newborn, what you would have done?
Bera or OE, ma'am.
Okay.
What are the cardiac anomalies do you see in CHAD syndrome?
Sir, tetralogy of Fallot is more common. VSD, ASD, transposition of great arteries, all these are seen in this case, sir.
Okay.
The next candidate, Dr. M. Madhuri.
Should I share my screen?
Sir, can I start? I mean, Nazima Begum.
She qualifies.
You want to present Dr. Nazima Begum?
Yes, sir.
Okay. Number 33, Dr. Nazima Begum. Ma'am, now the number is 33.
Yeah.
Dr. Nazima Begum, share your screen.
Yes, sir. Sir, is it visible, sir?
No, it is not visible. Yeah.
I think we finished it.
Okay, sir. Okay, sir.
Not yet as of now.
Okay, sir.
You can make it full screen.
Slide share, sir. Hello?
Yeah.
You make it
Sir,
full screen.
do I have to click on slide share?
Your audio is from two devices. You mute one of the device.
Okay, sir. Is it okay, sir, now?
Now it is okay. You make it full screen.
Full screen in the sense slide share, sir?
Yeah, correct.
Yeah, slide share. Okay, move to the next slide. Yeah, it is coming. Okay. You can start now.
My case case report is a case of unusual sinonasal sphenoid sinus malignancy in a young individual. Especially it's related to sphenoid sinus. Sphenoid sinus primary sphenoid sinus malignancies are very rare. 1 to 2% of all the sphenoid of all the paranasal sinus tumors account for sphenoid sinus malignancy account for 1 to 2% of all the paranasal sinus tumors. More common in the fifth decade of life. Occurs by primary sphenoid sinus tumors occurs by local extension from the surrounding structures. Signs and symptoms related to the sphenoid sinus malignancy would be headache, epistaxis, and cranial nerve palsies like third, fourth, fifth, and sixth cranial nerves, unlike the normal sinonasal malignancies. CT or MRI are preferred choices in any malignancy related to the sphenoid sinus because of the close proximity with the blood vessels and the nerves. And the treatment modalities would be a multimodality treatment, which includes a surgical intervention followed by chemotherapy and including radiotherapy. And recent advances have shown that proton beam therapy and stereotactic radiotherapy decreases the chances of morbidity. And the case we have reported in our hospital is a young male, 17 years old, which is quite unusual in cases of sphenoid sinus malignancies. And there are very few cases reported in the literature regarding this sinus malignancies, sphenoid sinus malignancies. Then now I'll start with the case report. We got a case of 17 years old boy who came to the ENT OPD with complaints of headaches on and off since 4 months and epistaxis on and off. There was no history of fever or head injury. And then 20 days later, he developed difficulty in moving both the eyes with normal, but the vision was normal. And there were no other complaints related to nose or throat or ear. On examination, nose, there was left DNS, middle meatus clear, no sinus tenderness, eye, proptosis with defective bilateral abduction, whereas the visual acuity was normal. On neck examination, we could feel a palpable bilateral level 2 lymph nodes, and on diagnostic nasal endoscopy, nasopharynx showed some suspicious mass. This is a DNA picture where we can see some suspicious mass in the nasopharynx. Then we have sent the patient for an MRI with a contrast, which showed enhancing mass in the sphenoid sinus and cavernous sinus and nasopharynx. Then we have planned for a biopsy, and we took the patient for an endoscopic excision of the mass from the sphenoid sinus, pus aspirated. We could encounter some pus which was aspirated and sent for gram stain and culture and sensitivity. Debulking was done as far as possible. We could do the debulking. We have done it, and then send the specimen for frozen and routine biopsy. Suspicion of fungal sinusitis or lymphoma was made depending on the pus and the consistency of the tissue. Then the frozen biopsy report came as atypical cells, possibility of malignancy, and then histopathology confirmed that it was a poorly differentiated squamous cell carcinoma. Then we have sent this thing for immunohistochemistry with a CK marker, creatine kinase marker. Epithelial origin of the tumor was shown, whereas with P40 marker, which confirmed the diagnosis as squamous cell origin of the tumor. Then during the course, during the treatment, after the biopsy and all, patient developed ptosis of the right eye. Patient was referred to an oncologist. Yes, sir.
Yeah, you have 1 minute.
Patient was referred to oncologist for further treatment. Then whole body PET scan was done with 18 FDG PET scan, and it showed a lesion in the basis sphenoid with intense FDG activity and bilateral level 2 lymph nodes with activity, highly FDG activity, and mildly active lung nodes. And as it is an extensive disease, neoadjuvant chemotherapy with injection of holoxan, fluorouracil, cisplatin in cycles was started, then followed by concurrent chemoradiation. Poor prognosis explained to the patient. Patient tolerated chemotherapy well. Successful chemotherapy. After successful chemotherapy, we sent the patient for PET scan again. Repeat PET scan after CT showed reduced uptake in the delayed stage. Radiotherapy started after chemotherapy. Dose of 70 gray in 35 fractions was given, kept under observation after chemoradiation. Headache and epistaxis subsided after chemoradiation, but ptosis persistent even after completion of chemoradiation. Later developed loss of vision. MRI of brain was done again, and it showed extensive progression involving cavernous sinus, stellar,
Dr. Nazima Begum. Your time is up. Yeah.
Okay.
Stop your screen sharing. And the next candidate, Dr. M. Madhuri.
Yes, sir. I'm ready.
Good morning, sir.
Number 35. Number 35,
Yes,
Dr. M. Madhuri.
Yes, sir. I'm ready, sir. Should I share my screen, sir?
Yeah, share your screen.
Good morning, sir. I'm number 30. Shilpa, can I present my...
No, you can present later.
Okay, sir.
Let Dr. Madhuri present first.
Yes, sir. Yes.
Number 35, Dr. M. Madhuri.
Yes, sir. Sir, able to see my screen, sir?
Yeah, make it full screen.
Yes, sir. You're able to visualize, sir?
Okay, yeah. Start your presentation.
Good afternoon, everyone. My case report is on a cervical scrofula, a rare presentation with pretracheal lymph node involvement. Tuberculosis is the most prevailing disease in countries like India, contributing to 22.7% of the global burden. Lymph node involvement is a common presentation of extrapulmonary disease. Cervical group of the lymph nodes are most commonly involved in tubercular lymphadenitis. This is a case of 33-year-old female who presented to our OPD with a complete nose swelling in front of the neck since 1 month. It was associated with pain and discharge. Pain was mild in severity, intermittent in nature, non-radiating. Discharge was whitish to yellowish in color, minimal amount and non-blood stain. There was no history of evening rise of temperature, cough, shortness of breath, no pain, difficulty in swallowing, no change in voice, no history of any other swellings. Past history, the patient had history of similar complaints of swelling on left side of the neck 2 months back, which was subsided with medication. Family history and personal history being nil significant. General physical examination is normal, vitals are stable, systemic examination is normal. Coming to the local examination, on inspection, there is an oval swelling of size 1.5 into 1 centimeter above the suprasternal notch, which is not moving with deglutition and protrusion of the tongue. On palpation, it was tender and mobile in horizontal and vertical direction. Remaining neck examination being normal, oral cavity, oropharynx, nose, ear examination is normal. Patient underwent ultrasound of the neck, which was showing a thyroid spore lesion and an enlarged bilateral level 4, 6 and supraclavicular nodes, at a discontinuity noted at level 6 lymph node with collection in subcutaneous plane, which was communicating with the exterior skin, which was suggestive of a ruptured cyst. Further, ultrasound guided FNAC of the swelling was showing Bethesda 2 grading. Thyroid profile was within normal limits. ESR was elevated. So this pus from the swelling was sent for AFP and CBNAT, which was suggestive of mycobacterial tuberculosis with rifampicin sensitivity. MRI of the neck with contrast was done, which was showing an ill-defined hyperintense collection in intermuscular, intramuscular planes of right sternocleidomastoid and along the medial aspect of the sternal head, extending into the cutaneous plane with a skin breach in the suprasternal region. It was also suggestive of an altered signal intensity in the vertebral bodies with cortical breaks and collection in prevertebral space. All these were suggestive of infectious spondylitis with prevertebral abscess. So based on the radiological findings of hyperintense collection and positivity for mycobacterial tuberculosis, this case is confirmed to be a tubercular abscess, and patient was started on a course of anti-tubercular treatment category 1 for 6 months according to RNTCP guidelines. Coming to the discussion, the pretracheal lymph node tubercular abscess is a rare presentation of extrapulmonary tuberculosis. They may present in any of the following stages like lymphadenitis, periadenitis, cold abscess, colloid abscess, or sinus. Most of the times, it spreads to a primary focus in lungs, tonsils, adenoids, mediastinal or prebronchial lymph nodes. The presentation of anterior group of the lymph nodes will mimic a thyroid swelling or thyroidosal cyst because of the location of the swelling and signs associated with it. The swellings anatomically located in the area of anterior group of the lymph nodes should be dealt with high suspicion for tubercular etiology, especially in endemic countries like India. I would like to conclude by saying that a proper radiological assessment is utmost importance to differentiate between a thyroid nodule and a lymph node pathology. A possibility of extrapulmonary lymphadenitis should be considered as a differential diagnosis in all cases of tubercular lymphadenitis. Adequate evaluation will avoid major surgical intervention in cases like infectious pathology like tuberculosis. These are my references. Thank you.
Ma'am, any questions?
No.
Okay. I'm calling the next candidate, Dr. S. Haritha. Dr. S. Haritha. Dr. S. Haritha. I'm calling the next one, number 37, Dr. C. Srilakshmi.
Yes, sir.
Share your screen.
Yes, sir. Sir, am I audible and is my slide visible, sir?
Yeah, you are audible. We are not able to see your slide.
Pardon me, sir. 1 minute.
Your screen.
Is it seen now, sir?
Yes.
Make it full screen.
Yes, sir. Is it seen now, sir?
You can start your presentation now.
Good morning, everyone. Today I am going to report a rare case of otalgia with multiple cranial nerve palsies. Introduction. Skull-base osteomyelitis is an infection of temporal sphenoid or occipital bones that is typically caused by complication of improperly treated otogenic or sinonasal infections. It is usually seen in elderly patients with diabetes or immunocompromised patients. It is often preceded by otitis externa. This may involve facial nerve, fifth nerve, sixth nerve, or carotid artery, jugular vein, including bulbar and hypoglossal nerves, and may further extend into petrous apex and also optic nerve. Facial nerve is most commonly affected due to its close proximity with EAC. Diagnosis is based on clinical features, which is unremitting otalgia, which is nocturnal in nature and deep and lanciating, and purulent otalgia, which on otorrhea, which on microbiological culture shows most commonly Pseudomonas aeruginosa and followed by fungal infections with Aspergillosis niger. Radiological changes are seen in skull base in either MRI, CECT, or CT. Treatment options include intravenous antibiotic therapy, hyperbaric oxygen therapy, and surgical intervention in case of failure of the previous options. My aim today is to report a case of 53-year-old male with uncontrolled diabetes presenting with otalgia. Case report. A 53-year-old male came to our OPD with complaints of pain in left ear since 4 months, which is continuous, throbbing type, aggravated during night, relieved temporarily with medication, and deviation of mouth to right since 3 months. Difficult to open a left eye since 1 month, and diminution of vision since 1 month. No history of hardness of hearing or fever of vomitings or seizures. No history of any nose or throat complaints. Patient had history of itching in right ear with cardioid discharge 4 months ago, for which he was treated with oral drugs and oral toilet. Patient is a known case of type 2 diabetes and he is a chronic smoker since 25 years. On initial evaluation, when he presented to us, we found his blood sugars were high. Later, we also found that on cranial nerve examination, there was ptosis of left eye and diminished vision in left eye. Only light perception was present, and all the movements of eye were restricted on left side, and mouth was deviated to right. Reduced palatal mobility was there, and gag reflex was absent. On examination of ear, we found that left external auditory canal was erythematous and erythematous, and tympanic membrane was retracted, and there was tenderness over the left tragus. Nose examination on anti-rhinoscopy and diagnostic nasal endoscopy showed deviated nasal septum to left, and there was no other abnormality. Oral cavity showed deviation of mouth to right, and there was grade 1 trismus. There was decreased movement of soft palate, and on larynx examination, we found to have a left vocal cord palsy. Based on this history, patient was initially diagnosed as skull-base osteomyelitis, and we started with him on IV antibiotic therapy, and further went on with investigations. Routine blood investigations were all were within normal limits except for elevated blood sugars. MRI brain showed a non-enhancing T1 hypointensity and T2 hyperintensity in left middle ear and mastoid, which was suggestive of left otomastoiditis with cholesteatoma probably. Computerized tomography of temporal bones also showed a soft tissue opacity in left middle ear and mastoid, which was suggestive of otomastoiditis. So, as I told initially, we started with intravenous antibiotic therapy, but patient did not show any signs of improvement. So, we further went on with left mastoid exploration under general anesthesia. Intraoperatively, we found that tympanic membrane was intact, and oscular chain was also intact. There was no obvious granulation tissue or cholesteatoma within the middle ear or mastoid. So post-operatively, to further investigate, we went on post-operatively by doing computerized tomography scan of nose and paranasal sinuses. CT-PNS showed a large distinctive space occupying lesion in left sphenoid sinus with erosion of its floor, roof, and extension into cellular space cavernous sinus, left pterygopalatine fossa, left orbital apex involving masticator and carotid space with extension into left middle ear, mastoid, and basal cistern. This tumor was debulked with endoscopical approach. Tumor was debulked using coplator. Intraoperatively, a pinkish irregular proliferative mass was seen in left ethmoid and sphenoid sinus. Tumor was subjected to histopathological examination, which was suggestive of undifferentiated squamous cell carcinoma. We referred patient to oncology department for further management, but we lost the patient within 2 weeks. Discussion: paranasal sinus malignancy constitute only 0.2 to 0.8% of all cancers and 2 to 3% of head and neck cancers. Primary sphenoid sinus tumors will constitute only 1 to 2% of all paranasal sinuses tumors. Unlike other paranasal sinus tumors present with nasal complaints, sphenoid tumors present only with complaints like headache, which is ipsilateral, retroorbital, deep boring type. Extension beyond the sphenoid sinus is very common, and treatment is by debulking and radiotherapy. By reporting this case, I want to conclude that appropriate preoperative radiological evaluation is necessary, and patient with unilateral headache should be evaluated thoroughly to rule out any paranasal sinus pathology. Early diagnosis can prevent intracranial complications. These are my references. Thank you.
Any questions, ma'am?
Preoperatively, you had not done CT scan, is it? CT.
Ma'am, we done the CT temporal bones, ma'am, but not paranasal sinuses.
But that would have shown little bit of the sinuses at least.
But there was no, we thought it is predominantly ear complaints were there, and entire master was showing
No
soft
problem, no
tissue.
problem. See, yeah, correct. We do CECT temporal bone, but that shows little sinus, and if you are in doubt, you could have done the diagnostic nasal endoscopy. That would have clinched at least.
Ma'am, diagnostic nasal endoscopy showed no mass, ma'am. There was only deviated nasal septum.
Okay. Okay.
Preoperatively,
Clinically
diagnostic
also
nasal
patient
endoscopy was done, ma'am.
Yeah.
Clinically also patient was having multiple cranial nerve palsies, like even second and third. Then would have seen properly before opening the mastoid.
Yes, sir, but his
Evaluated
initial complaint was facial nerve, sir. So we were suspecting ear pathology, sir.
Okay.
Okay. And the next presenter, Dr. Lakshmi.
Yes, sir.
5 minutes it's okay.
Yeah. Share your screen.
Sir, is
Make
the
it full
presentation
screen.
visible?
Yeah, you can start your presentation.
Okay, sir. Good morning, everyone. So I will be presenting a case of pediatric rhabdomyosarcoma of the paranasal sinus. So this child is a 5-year-old kid, female child. She presented to us with a left-sided nasal mass for a duration of 4 months. The mass was insidious in onset. Actually, her complaint was left-sided nasal obstruction for 4 months, which was insidious in onset, and it progressed gradually. There were episodes of epistaxis for 2 months duration. And for last 1 month, there is a mass which is protruding out of the left nasal cavity. And also she had complaints of proptosis of the left eye. So on examination, we found that the child is active, she is alert, and she is afebrile. Her general condition was fair. On examination of the nose, we found a bluish mass which is protruding out of the left nasal cavity. The mass was soft to firm in consistency. It is not sensitive to touch, and it's not bleeding on touch. And the left eye was proptosed, but vision and extraocular movements were normal. All the other systems examination were within normal limits. So we investigated the child with basic surgical workup and a CT scan, where we could see a soft tissue density in the left maxillary sinus. So HP was carried out. And in the management, we managed the child surgically with the excision of the tumor. The procedure was a limited maxillectomy with an external approach through Weber-Ferguson's incision, which was followed by the child was followed up with radiotherapy. The child was given 54 grays of radiotherapy over 30 days. So this is the incision, Weber-Ferguson's incision extending infraorbitally through the piriform fossa and extending downwards just lateral to the philtrum, ending in a lip-splitting incision. Then the maxillary sinus was exposed. The anterior wall was seen, anterior wall was removed with osteotomies. The mass was removed in toto. The mass was actually extending towards the entire left nasal cavity, inside the nasal cavity. So the mass was removed in toto, and then the sinus was packed with gel form. The anterior wall was reconstructed by using bone wax, and the wound was sutured in layers. So this is a post-operative picture of the child. So the histopathological examination showed multiple blue colored cells in the slides. So this was found out to be rhabdomyosarcoma, spindle cell variety. So rhabdomyosarcoma is a common soft tissue malignancy of head and neck in case of children. So the disease has a bimodal distribution. The first age group being 2 to 6 years, and the next age group being 10 to 18 years of age. Then in the first cohort of 2 to 6 years, mostly orbital variety is seen. The disease usually presents itself as a painless enlarging mass causing nasal obstruction. Sometimes there can be serious otitis, multiple episodes of epistaxis, there might be proptosis, and sometimes even meningeal symptoms might be there due to invasion. Most common investigations used are CT and MRI. In CT, there might be soft tissue densities seen, and also there might be bony erosions. In MRI, in T1, there will be iso-intense images. T2 will have hyper-intense images, and sometimes even flow voids may be seen.
1 minute left.
HPE will have the substantiating findings. Metastatic disease is common in lungs, bone, and the central nervous system. The management usually is local resection, followed adjuvant chemotherapy, and followed by radiotherapy. This is how the child recovered post-operatively. These are my references. Thank you.
Any questions, ma'am?
What was the site of origin in your case?
Sir, it was arising from the maxillary sinus, sir. Soft tissue of the maxillary sinus. It was arising from the medial wall.
Usually rhabdomyosarcoma will do well with radiotherapy. So if you could have gone for maybe that because of the child or very small, I don't know, endoscopic debulking of the tumor, and then you could have sent the patient for radiotherapy. I mean, my thought, that's all.
Oh, okay, ma'am. Okay.
The next candidate, Dr. K. Kavyasri.
Am I audible, sir?
Yeah, you are audible. Presenting candidates, turn on the video.
Is my screen visible, sir?
Yeah, make it full screen.
Good morning.
You can start your presentation.
Yes, sir. Thank you. Good morning, everyone. My case report is on neuroendocrine tumor presenting as an epiglottic cyst. Laryngeal neuroendocrine tumors account only for 0.6% of all laryngeal neoplasms. Most commonly, they are seen in 6th decade, and male is to female ratio is 3:1. They present most commonly with hoarseness of voice. They are divided into two broad categories based on the tissue of origin, epithelial or neural type. The epithelial tumors are further subdivided into typical, well-differentiated or grade 1 tumors, atypical, moderately differentiated or grade 2 tumors, which are most common, and small cell, poorly differentiated or grade 3 tumors. A case of 70-year-old male, construction worker by occupation, came with chief complaints of difficulty while swallowing solids since 1 month, change in voice since 15 days, cough with expectation since 15 days. Difficulty while swallowing was more to solids than liquids, which was insidious in onset, gradually progressed over 1 month. It was not associated with pain while swallowing, foreign body sensation. Change in voice since 15 days was insidious in onset, hoarse in nature, gradually progressive with no diurnal variation. It was not associated with throat pain. Cough was present since 15 days with expectoration, which was scanty, whitish mucor, non-foul smelling, non-blood stain, no postural diurnal variation, no seasonal variation, was not associated with shortness of breath. There were no constitutional symptoms. Past history and family history were not significant. Personal history, he consumes 90 ml of whiskey occasionally. He was chronic BD smoker for 10 years, 10 BDs per day, which equals to 5 pack years. General examination was normal. Vitals were stable. No pallor, ictus, cyanosis, clubbing, lymphadenopathy, or fetal edema was seen. Systemic examination was normal. Local examination, oral cavity, oropharynx was normal. Neck examination was normal. Nose and ear examination were normal. Indirect laryngoscopic examination showed base of the tongue, valleculae, median glossoepiglottic fold, bilateral, lateral glossoepiglottic folds were normal. A single ovoid, pinkish, smooth cystic swelling with well-defined margins visualized over laryngeal surface of epiglottis obscuring the bilateral arytenoids. Left aryepiglottic fold, bilateral falls into vocal cords. Right aryepiglottic fold was normal. This is the video of video laryngoscopy preoperatively, which shows base of the tongue, valleculae, median glossoepiglottic fold, bilateral lateral glossoepiglottic folds were normal. The laryngeal surface of epiglottis showing a single overt pinkish cystic swelling of size 1.5 into 1 centimeters with well-defined margins. Bilateral piriform fossa were normal. The bilateral aryepiglottic folds, arytenoids, falls, and 2 vocal cords were normal, and the movements were normal. Post-cricoid region, posterior pharyngeal wall were normal. The routine blood investigations were normal. ECG chest X-ray was normal. Ultrasonography of the neck was normal along with the 2D echo. The X-ray neck lateral view was showing a soft tissue lucency just behind the hyoid bone. The contrast enhanced CT scan was showing homogeneous thin wall cystic mass lesion in the region of epiglottis with no other abnormalities. Provisional diagnosis of epiglottic cyst was made and patient was taken up for microlaryngeal surgery and elective tracheostomy. This is the intro of video where the lesion was excised with wide-based surgical excision was done and the hemostasis was secure. Post-operatively, the patient was started on antibiotics, analgesics, and the regular tracheostomy care was taken later. This is the post-op video laryngoscopy after the 2 weeks, showing no abnormality, no recurrence of the tumor, and no other abnormalities of the laryngeal structures were seen. The histopathological examination showed small round cells which were arranged in S and trabeculae, which was suggestive of neuroendocrine tumor. Immunohistochemistry was positive for synaptophysin and tomogranulin A. Neuroendocrine tumors are distinguished from other tumors based on cell morphology and immunohistochemistry. The well-differentiated tumors have best prognosis and rarely metastasize. The conservative surgical excision with regular follow-up is usually sufficient, and elective neck dissection is not necessary if no lymph node
You have 1 minute.
for the diagnosis. Accurate grading by histopathological examination and immunohistochemistry critical for diagnosis, planning, treatment, and prognosis of neuroendocrine tumors. Those subtypes of neuroendocrine tumors share similar immunoprofile. There are clinical and prognostic differences. Survival and prognosis data of neuroendocrine tumors is scarce due to rarity of the well-defined, well-differentiated neuroendocrine tumors. Hence, regular follow-up is needed. These are my references. Thank you.
Any questions, sir, ma'am?
No. We can go for the next candidate.
Yes. Number 40, Dr. Niranjana.
Good afternoon, sir. Am I audible, sir?
Yeah, you are audible.
Okay, sir. I will share my screen, sir.
Increase your volume.
Okay, sir. Good afternoon, everyone. I'm going to present a case report of chronic invasive fungal rhinosinusitis in adolescent patient. Introduction. Chronic invasive fungal rhinosinusitis is a sub-entity of invasive fungal rhinosinusitis with fungal invasion to the soft tissue of nose and paranasal sinus, affecting usually immunocompetent patients. The chronic invasive fungal sinusitis often gradually progresses over a period of months and can lead to invasion to neighboring structure. Possible medical manifestation including proptosis, altered mental status, seizures, and intracranial complications. Chronic invasive fungal rhinosinusitis in immunocompetent patients require a better of better treatment as chronic symptoms and sign might mimic other type of sinusitis, resulting in ideal treatment delay or misdiagnosis. Chronic invasive fungal sinusitis can be categorized into granulomatous and non-granulomatous form based mainly on the presence of submucosal granulomatous inflammation with the fungal hyphae and extensive fibrosis. Here, I'm going to present a case of a 14-year-old female came to ENT OPD with the chief complaints of bilateral nasal obstruction since 1 year. And history of presenting illness, patient was apparently normal before 1 year. Then she developed a symptom of bilateral nasal obstruction, which is insidious in onset, gradually progressive for the period of duration of 3 months with no aggravating and relieving factors. And she has a history of bilateral watery nasal discharge, which is mucoid in nature, non-foul smelling, and history of mouth breathing present. And she has no history of bleeding from nose, sneezing, loss of smell sensation, headache, decreased vision, either fever, cough, loss of appetite, weight loss. And past history, no significant past history of diabetes mellitus, hypertension, history of steroid intake, and her vitals are stable with a temperature 90 degree Fahrenheit, blood pressure of 110/70, and pulse rate and saturation with 90% room air. On local examination on anti-rhinoscopy, when visualizing nasal septum, it's slightly deviated to left side, and nasal cavity, a polypoidal mass involving both right and left nasal cavity, which is non-tender, doesn't bleed on touch, and probe moves all around the mass. On PNS examination, bilateral maxillary sinus tenderness present. And the investigation, it was a very normal value with a hemoglobin 10.5, total leukocyte count with 7,600 cells, and platelet count with 2.26 lakh, and absolute neutrophil count with 4,500 cells, and RBS, and blood grouping typing of B positive and everything. On these are the visualization with the diagnostic nasal endoscopy. On radiological examination of a CT paranasal sinus, a mucosal thickening and hyperintensity noted in both the bilateral maxillary ethmoidal and frontal sinus, and erosion of bilateral ethmoid sinus and bone wall noted, and bilateral osteomeatal unit blockade noted. Management. After all the pre-operative occurred, patient is posted for surgery under general anesthesia. Patient underwent functional endoscopic sinus surgery, and during intraoperative finding the right nasal cavity, fungal debris present over the area of middle meatus, and in left nasal cavity mucosa edema with fungal debris present over the area of middle meatus, and the fungal debris removed and sent for histopathological and KOH mount. And these are the intraoperative findings of that patient. And the histopathology of removed tissue showed tissue branching septal fungal hyphae consistent with Aspergillus species. On KOH mount, revealed the presence of thin hyaline septae hyphae with acute angle branching. And about discussion, fungal sinusitis severity ranges from non-invasive, that is fungal ball allergic fungal sinusitis, to invasive acute or chronic fungal infection based on pathogenicity of fungal species, the immunological status of host, and overall complex cellular and humoral responses. Chronic fungal sinusitis are prevalent among both immunosuppressed and immunocompetent hosts, unlike chronic invasive fungal sinusitis, which typically present in immunocompetent hosts. Aspergillus flavus is the most common parasitic organism in most cases of granulomatous and non-granulomatous fungal rhinosinusitis. Invasive fungal rhinosinusitis can be life-threatening if left untreated. In the present case, the patient was immunocompetent and no history of steroid intake or diabetes was present, and no invasion to orbit, infratemporal fossa and cavernous sinus, which favored our and the patient underwent surgical debridement followed by medical management of itraconazole 200 mg twice a day for 3 months. And coming to the conclusion, chronic invasive fungal rhinosinusitis often progresses gradually over a month, and early diagnosis and management of chronic invasive fungal sinusitis improve clinical outcomes. Surgical debridement with effective antifungal therapy plays a key role in management of invasive fungal rhinosinusitis. The overall mortality with invasive fungal rhinosinusitis remain high, although patients with no comorbidities have a better overall survival than patients with comorbidities. Thank you.
Niranjana, in your case, what antifungal you used post-operatively?
We used itraconazole, ma'am, 200 mg twice a day.
Better antifungals for invasive aspergillus, because it is invasive aspergillus. Yeah.
Yes, ma'am, we can use amphotericin B, ma'am. But with amphotericin, more side effect compared to itraconazole. Nowadays, itraconazole is a better usable.
Any other oral antifungal you have?
Yes, ma'am. Itraconazole, osaconazole, we can use, ma'am. Isoconazole, you can use, ma'am.
Usually invasive, either amphotericin or posaconazole or voriconazole we give.
Oh, okay, ma'am.
Okay. Yeah, hyperdensity areas on CT scans, what do you call it as?
Hyper.
Did you ask any positivity, COVID positivity in the history?
Yes, sir. We have asked the history of COVID positivity. She was not COVID positive, sir.
Okay.
Okay, sir. I'm going to call missed candidate's name. Number 24, Dr. Vrinda Ullas Nair.
No, she was not well. She's unable to present, I think.
Okay, sir. I'm calling the next one. Dr. Yunus Fatima. Number 29, Dr. Yunus Fatima. Okay. And number 30, Dr. K. Shilparani.
Yes, sir. I'm here, sir.
Okay. Share your screen.
Yes, sir.
Ranjana, you can stop your screen.
Good morning, sir. I'm presenting the case of nasopharyngeal carcinoma in among the pediatric age group in a non-endemic region. Introduction. Excuse me, sir.
Yeah, you can start.
Yes, sir. Introduction. Nasopharyngeal carcinoma is an extremely rare malignant lesion in pediatric age groups before second decade of life. The relative rarity of the nasopharyngeal carcinoma makes the diagnosis difficult. This rarity often associated with the delayed diagnosis, which may lead to the advanced loco-regional disease. I couldn't able to move the screen, sir. Yes, sir. Case presentation.
Yeah.
This case initially presented to the pediatric department with the bilateral swellings. Chief complaints of the bilateral swellings, history of present illness. Patient was apparently asymptomatic 5 months back. Then he noticed the swelling over the upper part of the left side of the neck, which below the mandible, insidious in onset, gradually progressed for the duration of 5 months. Initially ground nut size and gradually progressed to the lemon size, not associated with the pain. History of the similar complaint present on the right side, insidious in onset, gradually progressed for the duration of 3 months. It was initially pea-sized and gradually progressed to the almond size. History of excisional biopsy done in a pediatric department in 2 months back, that came out as a reactive lymphadenopathy. Further, they given a not greater than right, gradually progressing for the duration of the 2 months, initially developed left side, then progressed to the right side within a duration of not aggravating, relieving by the medication. Associated symptom, post-nasal and last one, and left-sided pain, left-sided, sir. Past history not significant, personal history normal, history of exposure to asbestos is present because the patients are involved in the elderly. General examination, no abnormality detected. ENT examination, I want to discuss about the positive signs on left side. Abundant mucus discharge present under anterior rhinoscopy, posterior rhinoscopy, proliferative mass completely covered with the slough in the nasopharynx, eustachian tubal opening at the choana not visualized.
And paranasal sinus, all sinuses are normal, except the maxillary sinus tenderness is present, and the functional test cold spatula decreased misting on both sides, and the cold wool test decreasing ears. I want to discuss about the left side past tense of grade 1 retraction is present, and the cone of light decreased mobility present, right side normal. Functional test which reveals the conductive deafness on left side. Examination of eye normal. Oral cavity examination, oropharynx examination normal. Posterior pharyngeal wall, we can see the bulging on a posterior pharyngeal wall. Examination of the neck. Level 5 lymphadenopathy was present on the single oval swelling approximately 6 into 5 centimeters above the supraclavicular fossa, which is a normal surface. Scar is presented because non-tender and firm in consistency, mobile in a horizontal direction. Skin over the swelling pinchable. Right level 5 lymphadenopathy is single oval swelling approximately 4 into 3 centimeter normal in surface, non-tender. Mobile in a both direction, no obvious thyroid swelling, trachea midline, laryngeal test present, and bilateral calotid spells. My provisional diagnosis according to the history: nasopharyngeal malignancy, bilateral secondaries in the neck. Differential diagnosis: lymphoma, angiofibroma, adenocarcinoma, neurofibroma, and rhabdomyosarcoma. Diagnostic evaluation done through these investigations and DNA examination. A single proliferative mass present in the cornea, obscuring the view of the left side of the eustachian tube, torus tuberous, encroaching up to the left side of the posterior pharyngeal wall, anteriorly extending up to the nasal cavity, which is bleeding on touch. CECT PNS, we can see the mucosal homogeneous opacity present in the nasopharynx and superiorly extending up to the temporal lobe, abundant the temporal lobe, and inferior laterally it is present to the parotid. Yes, sir. This is a tumor extension, and endoscopic guided biopsy under general anesthesia, which HPE revealed tumor cells with a hyperchromatic nuclear conspicuous nucleoli. Impression came out as a poorly differentiated nasopharyngeal malignancy. This is the post-induction chemoradiotherapy. Tumor was reduced in a gradually. He was given the cisplatin along with the radiotherapy, and in a conclusion, all patients who has a persistent bilateral cervical lymphadenopathy should be subjected to the proper ENT evaluation for a proper evaluation of the nasopharyngeal carcinoma and a basis of the biology of the NPC. It's a clear administration of the effective chemotherapeutic agent is needed for the treatment of the childhood NPC, and long-term follow-up and treatment-related morbidity and second primary malignancy are routinely observed. Thank you, sir.
What is the TNM staging here?
Ma'am, it is a T4N2MX, ma'am.
Any virus you want to check for in this?
Yes, ma'am. Epstein-Barr virus, ma'am.
It was done?
Yes, ma'am. IHC marker was done for this patient. It came out as a positive, ma'am.
Positive. If it is positive, it's a good prognosis or no?
Bad prognosis, ma'am.
Which group of lymph nodes are commonly involved in nasopharyngeal malignancy?
Level 5 lymph nodes are most commonly involved, sir. Retropharyngeal.
What is sandwich therapy? Hello?
Dr. Shilpa?
Okay.
Sir, we are calling the next candidate. Number 32, Dr. N. Sriharsha.
Followed by the chemotherapy, sir. Yes, sir.
Okay.
Yes, sir.
The next candidate, Dr. N. Sriharsha. Okay, and number 36, Dr. S. Harita.
Yes, sir. I'm audible, sir.
Yeah, you are audible. Share your screen.
Yes. This audio is visible, sir.
Yeah, your audio is audible.
Still, she is not come. Is this lane?
Screen is visible, sir.
No, not yet as of now.
Screen is visible, sir.
Okay, it is visible. Make it full screen.
Yes. Can I start, sir?
Okay, you can start your presentation.
Hello.
Yeah, Dr. Harita, you can start your presentation.
Yes, sir. It is a rare combination of congenital anomaly of the external ear with congenital cholesteatoma. External aortic canal. 1 minute.
Sudha Kalsogappa.
Hello, sir. Sir, am I
Yes,
audible,
yes.
sir? Hello.
Yeah, continue.
Sir, am I audible, sir?
Yeah, you can.
You are audible. Continue.
Congenital external aortic canal atresia is a relatively uncommon condition with incidence of 1 in 10,000 to 20,000 libers. Unilateral occurrence is more common than bilateral. Congenital cholesteatoma is also one of the rare diseases of the temporal bone and has been reported to be present in 4 to 7% of the cases of congenital external coronal atresia. Case presentation: a 14-year-old male patient presented to the ENT department with chief complaints of bilateral hard of hearing since childhood. History of present illness: patient was having bilateral hard of hearing since childhood, which was gradually progressive, and presently he is able to hear loud sounds and telephone conversations, but not able to hear whispering. Past history nil significant, family history nil significant, personal history normal, general examination normal, vitals are stable, systemic examination normal. Ear examination, right ear and left ear preauricular sinus is noted. Pinna grade 1 microcephaly is rotated on both sides. Post-auricular is normal. EAC narrow aural stenosis is visible. Aural stenosis is present on both sides. Tympanic is not visible. Master tenor is absent. Facial noise is intact. Tuning form test denition is negative on both sides. Web size is lateralized to left. Absolute bone condition is decreased compared to the examiner on both sides. Nose examination, oral cavity, oropharynx, neck examination is normal. Pewter investigation, Pewter odometry, right ear 63.8 decibels, severe conductive hearing loss is present. Left ear 68.5 decibels, severe conductive hearing loss is present. High-resolution complete scan of the temporal lobe shows bilateral microcephaly with severe stenosis of the external auditory canals. Soft tissue application seen in the left medial ear and master suggestive of congenital cholesteatoma with mastoiditis. Dysplastic ossicles were noticed bilaterally. We can see this bony partition seen that areolar atresia is thin and bony partition is thin. Magnetic resonance imaging of temporal bone. Evidence of patchy T2 hypertensy area noted in left ear with a hypodensity and higher incidence signals on diffusion weighted MRI in mastoid cholesteatoma. Bilateral stenosis of the external auditory canals. Mild hypertension signals in left auditory canal edema. 7th and 8th nerve complex are normal on both sides and cochlear and semicircular nerves normal. Diagnosis: bilateral microcephaly with bilateral stenosis of the external auditory canal with congenital cholesteatoma. Management: we have done left modified articular hysterectomy with type 4 tympanoplasty plus left preauricular sinus excision plus left myotoplasty done and a general anesthesia. Entopy findings: descent in facial nerve was noted. Dysplastic ulcers are present. Malus attached to anterior wall of the EAC and only stapes footplate was seen. A bony horizontal partition was noted in the external aortic canal, separating it from the accessory canal, which was just posterior to aortic AAC. Cholesteatoma sac with purulent discharge was noted in the middle ear and mastoid, which was excited in total. Floor of the EAC and middle ear was deficient. Left MRM with myotoplasty was done, and defect in the floor is covered with temporal fascia graft, pattern cartilage. Immediate post-op patient had temporary grade 2 Hofmann-Brachmann facial palsy. Post-op day facial nerve status was normal. Here we can find facial nerve deficient is there, tympanic segment. Extra canal is noted, and there is a bony partition in the extra canal, and this is called an tympanic mastoid cavity. Here deficiency of tympanic segment facial nerve is noted. The discussion: the diagnosis of congenital cholesteatoma with congenital atresia was rare, and incidence of cholesteatoma is higher in congenital atresia. Both the components of external ear and pinna and external auditory canal augment and transmits on weight with tympanic membrane. Invasion of ectodermal element of first pharyngeal pouch forms EAC. It grows medially to meet the endoderm of middle ear. Mesodermal entrapped between these two ventral and dorsal sides, giving rise to meatal plug or plate. This plate reabsorbs by the end of 28th week of gestation and the external auditory canal precanalization. Failure of regulation leads to congenital oral atresia. Colostrum is rarely primary lesion, which helps in epithelist and ectodermal origin in the petrous bone. This plate in and around the labrum extended the medullary cleft. When canal atresia is associated with colostoma, the patients present late with features like facial nerve palsy, hearing loss. Consultations of the tympanic segment of the facial nerve is the most commonly seen anomaly of the facial nerve. Both the above-mentioned diseases can occur independently, but the presence of both these entities is a rare occurrence and needs high degree of suspicion aided by the computed tomography, scan, and magnetic resonance imaging to make the diagnosis. Conclusion for hearing reevaluation in children with congenital external anomalies, we can use anchoring hearing aids, bone anchoring hearing aids are the treatment option available. In this case, patient was associated with congenital colostoma, hence the option of the surgical intervention was planned. The surgeon could be warned and very cautious of possible facial nerve anomalies when microtia and oral atresia are present. In isolated congenital malformation of the ear, however, very limited information on the facial nerve may be available before surgical extraction. Accurate preoperative radiological assessment of facial nerve course and other anomalies is essential and play a critical part of the surgical plan and provide conclusion. These are my references. Hello. Hello, sir.
Yes, yes. Ma'am, any questions? Sir?
Yeah, how long you followed this patient, Harita?
For 2 months, ma'am. 2 months, ma'am, we followed.
Okay.
From after surgery, 2 months we followed, ma'am.
Okay. What was the ossicular reconstruction done here? You did any?
We kept it top.
What are the? How do we classify congenital cholesteatoma?
We kept the PORP, ma'am. Partial.
Okay. You used a synthetic.
Ma'am, pardon, ma'am.
How do you classify congenital cholesteatoma?
Based on theories, we have to classify, ma'am. Epithelial. Will cause a conjecture and
Microtia, are you planning to do later?
yes, sir. Ma'am, it is grade 1 only, ma'am.
Grade 1.
Clinically.
Okay. Okay.
Yes, ma'am.
Yeah. Okay then.
Manoj, any leftover? Hello, Manoj, are you there?
No.
Dr. Ramesh, sir?
Manoj, any leftover?
Sir, we have done, sir. Done with the presentations.
Okay, okay. Thank you so much. Bharati ma'am and Prabhakar sir. Thank you, sir.
Thank you, Dr. Ramesh. Thank you, Harsha. And thank you, Bharati madam. And congratulate all the participants. You have done very well. And also congratulations to your HODs of your concerned medical colleges. Keep going. Thank you.
Okay, sir.
Thank you, sir.
Thank you, everyone.
Thank you, ma'am. Thank you, Sriharsha and Manoj team, for all your efforts. Thank you so much. Yeah, we will.
Thank you, sir.
We'll be at a physical conference on 16th and 17th, 18th. We'll meet there.
Okay. Bye.
Definitely.
Bye, ma'am. See you, ma'am.
Bye. Bye.
Harsha, you can close the session.